Good afternoon. Hello. Hello and welcome. I know we have a few people still joining us from the outside room, but I want to welcome you. We have a new location here in the Twin Cities for this event, and I learned that some of you were wandering around our last location, so I'm glad that you've all found us. Welcome. My name is Carrie Michaels. I am the coordinator of the Center of Excellence in Children's Mental Health, and this is our final event in our Lessons from the Field Attachment series for this year. I welcome those of you who are here at the university, including those who are outside our room today. We didn't have enough space inside this auditorium, so we have an overflow outside the room. I also welcome all of you participating at our many host sites throughout Minnesota. As with our other events this year, we have about 800 people participating through video stream or interactive television at sites throughout the state. The participation of all the folks in Greater Minnesota have helped us with planning and discussion and evaluations, and we're really grateful that we have such a wide audience throughout the state. In case some of you have been here all year and don't know the purpose of this session, I would like to tell you that Lessons from the Field is part of our center's larger purpose to bridge research and practice. This is a two-way bridge, and it's really critical for us that we're bringing research to people who can use it immediately in their practice, and that we're also asking practitioners what works well for you so that we can inform researchers, and we can also inform funders who fund research. So we're really trying to bring a number of people to the table, coordinate these sessions so that you're hearing from researchers and practitioners. This session in particular, we'll hear from quite a few speakers who have used attachment-related research in different types of practice settings. Today's event moves us to the practice end of the spectrum. It's about intervention and treatment models. And before moving on to our speakers, I'd like to thank our many co-sponsors for this year's series, and you can see a list of them on the bottom of your agenda. We're also grateful for the President's Initiative on Children, Youth, and Families, which funds our center. It's an interdisciplinary effort here on campus from President Bob Brunix. We are also grateful for the Children, Youth, and Family Consortium, which houses our center and supports our activities. A few housekeeping details about today before we begin. For those of you here at the University of Minnesota, there are refreshments and restrooms outside the auditorium to your right. We'll have a 15-minute break during today's session from 2:30 to 2:45. And a reminder to please turn off your cell phones during the presentation. And then you also should have a copy of today's main PowerPoint presentations in your packet, and you can follow along with the speakers. If there are speakers who don't cover all the slides in their presentation that you have in your packet, please don't worry. Or if they have new slides that don't appear in your packet, that happens sometimes too. We have the full completed version of everybody's PowerPoint presentation on our website. So if you hear something and you don't have it in front of you or you don't get it jotted down, you can go to our website, which is also listed at the bottom of your agenda, and find all the information from today's presenters. And it's also very important to us today in particular to complete your evaluation forms. This has been a year-long process, and we did the planning for this a year ago. We have added some questions on your evaluation form that will help us plan for next year and really value your expert opinion. You're who we're doing this with and for, so if you can take time, particularly today, to fill that out, we would appreciate it. So now I'm really pleased to introduce our keynote speaker for today. Dr. Ann Gearity is a clinical social worker in independent practice and a consultant to schools and community programs. She is an adjunct faculty member here at the university's School of Social Work and on the field faculty for the Harris programs, also here at the university, and is a principal consultant for Washburn Child Guidance Center's day treatment program in Minneapolis, where she works with staff to evaluate a treatment repair model for very young children. We also today have 4 respondents, and I am going to tell you who they are, and then you'll learn a little bit more about each of them as they speak later on today. Deena McMahon is the Director of In-Home Services at Therapeutic Services Agency. Denise Lacher is the Family Attachment Center's Director of Attachment Programs. Tom Steinmetz is the Program Director for Washburn Child Guidance Center, and Krista Nelson is Project Coordinator for the Wilder Foundation Center for Children with Reactive Attachment Disorder. So please join me in welcoming our keynote speaker, Dr. Ann Gearity.
Now, this is where we could run into problems, okay? and show, and show. So I should be able to talk and do this at the same time. So I will try. I'm delighted to be here, and before I do anything, I just want to thank I want to thank Carrie Michaels and Ellen Lipinski. This project has been of enormous woman power, and to have all the sites in Greater Minneapolis included has been incredibly innovative. I also want to ask you to tell anyone that you know at the university about this project and your experience, because I think community-based programs don't always get as much recognition as they should. So if you see President Brunick this afternoon, let him know. Now, let me tell you a couple of things. I do change my slides. I can't not. And so I will send my corrected slides to Ellen tonight, and you can get them on the website. We're going to have questions perhaps after I talk, but mostly with the panel. So hopefully we'll have lots of time and be thinking of your questions as we go along. And the format today is guaranteed to be frustrating because we're going to try and pack in less than 3 hours what we could spend days doing. So please think of this as a beginning of a conversation rather than as an end point, and hopefully we'll keep going. What I'm going to do today is figure out how to make this work. Okay, so we're going to review what we've learned so far because this is the fourth of the series. We're going to build a clinical lens that recognizes how attachment contributes to normal building blocks and identify the deficits. For those of you who know me, I always have to start with normal. So I have to embed attachment in normal development, and then we can more easily see when it goes awry. The third thing we're going to do is we're going to examine 4 programs that use attachment-related research. And what I want you to be listening to as I talk are some of the common threads that need to be available in attachment repair. And then we'll listen to how they have taken these ideas and turned them into practice. And finally, we're going to discuss how we use this knowledge in community practice with our most vulnerable children, the ones you work with. So, just as a quick review, Marty Erickson started us out in the fall, and what she did was identify the attachment research protocol. So just to remind all of us, this is research that's been done over a 40-year span, and this percentage stays consistent. 70% of us are securely attached. So that's good news. That's good news. The human evolutionary process is working. 30% of children are vulnerable, and they often develop patterns that we call 3 names: avoidant attachment, ambivalent attachment, or disorganized attachment patterns. And Marty introduced us to these. Marty also made a very important point that parental histories influence present attachment systems. So in attachment, we can really see how intergenerational transmission occurs. And people who have had their own vulnerable attachment experiences are more at risk to perpetuate that inadvertently with their own children because attachment is largely unconscious. But we also know, and Marty told us about her program, the STEEP program, that there's a possibility of attachment repair through parenting. And she called it developing a secure, autonomous state of mind. So if you don't luck out in your first 5 years, it's not the end of the process. And the more that you can stay open to understanding what attachment provides, the more there's a chance of repair. So Marty told us about that. Now the second workshop was Charles Zeanah, who came from Tulane. And remember, he told us about attachment affiliation, which develops over time. Attachment is not a phenomena that happens at the moment of birth. Rather, it's through a gradual interactive process. He described the attachment exploration balance. The more the child is attached, the more they can explore into their world as their body is able. He talked about safe base and secure base and safe haven behaviors that were evident by a year. All right, so by 1 year, we can see how children are learning. He had a quote, "The infant's quality of attachment to primary caregivers is one of the strongest predictors of psychological and social outcomes in middle childhood and adolescence." So while this is a phenomena that is about early development, the effects or the sequela of attachment carry into middle childhood adults, and we could add, because there's now research that shows that it also influences lifelong patterns of friendship and relationships. All right, so Dr. Zeanah also described for us disorganized attachment, and he used that idea of the frightened, frightening pattern. Now, I'll come back to this. The reason that this is important is that while the other two attachment patterns lead to some adaptive peculiarities that have cost, the disorganized attachment pattern is the one that shows very early signs of later psychopathology. So this is the one we're very concerned about. And he also talked about disorders of non-attachment or reactive attachment disorder. And he introduced us to some of his work with children who are growing up in institutions. The third workshop was at Reed Sulik, and what Reed told us about was that attachment has to be considered as a possible etiology, not a diagnosis. So this is very important. There's no diagnosis, anxious avoidant attachment. In fact, in the DSM, there's only reactive attachment disorder of childhood. There isn't any category that describes attachment anxiety or difficulties. So we're often stuck diagnostically. He talked about mental health factors that may interact with symptoms of attachment difficulties, and I listed them, so you'll all have them. And he also talked about the importance of assessment, of both looking beyond and underneath behavior, and he urged us to understand that a complex diagnostic picture assures the best intervention plan, and I'll pick up on this. He also talked in his presentation about mindfulness techniques and words, and I thought this was a good way for us to start. Words we choose. We can say stop it, we can say calm yourself, or we can say let's calm. And he was introducing this idea of an attachment state of mind when we relate to children. So now we're here. So what is attachment really? And how do we make this research clinical and practical? Now I have to warn you, I have a lot to say, so I'm going to talk very fast. Okay, ready? So this is a drawing just to capture what the earlier speakers told us. The child in the attachment system gains increasing capacities over time with developmental experience. It's very important for us to remember that attachment is a dynamic process or system, and the system continues to support development under good circumstances or detract from developmental capacities under difficult circumstances. All right? So I came up with 8. And this is an inclusive list. And one of the things we may find as we talk is that we'll add more. So attachment, the qualitative effects of attachment include survival, physical and emotional sustenance, co-regulation of arousal, self-regulation of emotions, which includes recognition and modulation, social introduction to the larger world, social membership, mental awareness of self and other, mind reading and mind sharing, exploration, moving out from the parent, and finally coherence of experience. So I'll talk about those 8 very, very quickly. So the parent job, the number one parent job is attachment is an evolutionary phenomenon that is about survival. And we always have to start there. The human species dies if it is not cared for. The baby cannot survive without the care of others. So it's about survival. It's about why parents get up in the middle of the night and feed their baby even though they're tired, because the baby can't survive unless the parent is interested in keeping that baby alive. The parent is charged to watch out for the infant and to make sure the baby is not lost to predators, dangers, or other misfortunes. And we share that with our mammal cousins. Survival is critical, non-mammal as well. Survival is critical for every species, and adults must provide and transmit essential survival skills to assure perpetuation. So we have two pictures. I use ducks because Conrad Lorenz started with geese, but we have the parent job, the good job, make way for ducklings, and then we have the bad parenting, right? Right? She forgot to look out for her kids. I mean, it's that basic. See, pictures work. All right. All right. So the second outcome, see, we can't linger over this laughter. I got work to do. The second outcome is sustenance. The infant looks to the mother or other for care and comfort. And when we talk about sustenance, we're talking about physical sustenance, but we're also talking about emotional sustenance. And this is where we shift. Our species has a very unique quality because we talk about the attachment state of mind. It's not just making sure the baby is fed and protected, but it's also that the baby is thought about. So this is where we move into the psychological. The third is the system of mutual regulation. And I use this because it's very important for us to understand that it is a system, and both the parent and the child are equal members in the system and are equally affected by the system. We hope the parent has more resources than the child. But for some of our families, the attachment system breaks down right here because the parent doesn't have more resources or their resources are compromised. When the baby is doing well, the parent feels attachment successful. When the baby is struggling, the parent is also struggling. So that's why the child's temperament is so important. This is not a one-way street. And I have a cartoon. I have to spend quality time with my parents or they'll become dysfunctional. That's true. All right? It's not just about parents not taking care of babies. It's about babies engaging parents. All right? What each partner brings. The parent brings availability, reliability, preoccupation, willingness to see the child's needs, supplemental functioning, awareness of the parenting role, predictable care, and ability to support. The child brings seeking connection, motivation to attach, to use the parent, increased differentiated needs satisfaction, gradual self-functions, growing sense of self, expectancies and strategies, and the ability to generalize attachment security to include new caregivers. So the baby is also active, and the parent is trying to help that baby to be active as an attachment partner. When that doesn't work, the parent system within the attachment system is unduly distressed. Now, right, the fourth thing is the attachment system provides help in moments of fear and distress to assure self-regulation learning. Not training is too mechanical, learning. So what the attachment system is doing is, and the best definition of attachment functioning I've read is that the attachment system is most activated in moments of distress. The baby alerts the system. I need you. The system responds. The baby learns. Every time I am distressed, my system responds. Sometimes the system takes a few minutes, but because the baby knows the system will respond, the baby has the ability to start to develop strategies that engage the parent. So if I cry, my parent doesn't come, what do? I cry a little louder. That's my strategy. So these expectancies and strategies are very carefully balanced interactive patterns that assure the attachment system will work when it's necessary. Now, as the child gets older, the attachment system says you don't have to cry so much. It's just a little bump. And the child learns to be self-regulating. So that's the important thing, that the attachment system helps the child learn the very critical neuropsychological capacity of self-regulation. As the child moves from mutual to self-regulation, the child waits or expects the parent to come to the rescue. I've talked about that. These are points of heightened arousal intensity when the child is especially vulnerable to dysregulation. Now, why this is so important is that in normative development, those moments of distress are exactly when the attachment system has action. What we'll see as we look at intervention programs is that often we've misplaced our action. And when children with attachment problems are distressed, staff say things like, "I'll ignore him." And we miss the critical neurological opportunity to repair. Finally, over time, these expectancies gain predictability. And it's the predictability of the expectancies and strategies that allow the baby to say, "I don't have to worry about it, she'll come." Right? And that's what allows the self-regulation to really become active. So we have this chart. This is called mid-range arousal. Always when we're talking about self-regulation, we're talking about arousal. And under optimal conditions, we stay aroused to a mid-range amount. Now, what mid-range is for me may be different from you, but the mid-range is where my body and brain is enough awakened that I know this is important, but not so awakened that I'm in unbearable pain. And over time, the baby learns gradual self-learning, and then they can return to a state of homeostasis. So this is a picture that we're going to come back to. Now, the fifth attachment outcome has to do with emotion and social cognition. And one of the things we know now is that the brain has two sides, two hemispheres. The right hemisphere involves more visual, spatial, and emotional learning. The left hemisphere has more language and logic. The right hemisphere is the primary hemisphere online the first 3 years of life. So attachment is a right hemisphere phenomena. And in that attachment experience, the child learns not only to count on my mother or father, but to learn the rules, to learn about social cognition, to learn how to read faces, to learn how relationships work, not just with my mother, but with everyone. All right? The sixth attachment outcome that we want to think of is a mental awareness of self and other, and you'll see how this plays into the interventions. Attachment experience is represented internally. So in the literature, we talk about internal working models that are acquired through imitation and anticipation. Now, these inner working models are inside the child's mind. They're not conscious. It's not that the child says, "Oh, I think I'll use my attachment pattern with you." These are pre-conscious, automatic responses to what the child perceives and expects. Out of this comes what we now know is a mentalizing function, and I called it mind reading, mind sharing. Many children with attachment disorders share with children with autism, although from a different etiology, a kind of mind blindedness. They don't know how to read what's on your mind. They can only see what's on their mind and project it. So this ability to read other people's faces and minds, to say, "Oh, I know what you're thinking because I'm thinking it too," is a critical phenomena that comes out of the attachment. The baby knows she has a mind because her mother recognizes her mind and then helps her learn about others' minds. Now, what this allows for is predictable social interactions. I'm reading your minds. I'm reading your faces. If one of you scowled at me right now, it would throw me a little because I'd say, "Whoa, I thought I was okay, but maybe I'm not." Right? We do that all the time. We're constantly orienting ourselves in a social context. It also, this mind reading and mind sharing, lends to an emotional self-control that allows me to have a sense of agency. So that leads me into the seventh attachment outcome, which is exploring. So Dr. Zeanah said as attachment becomes secure, the child is able to explore. The child is able to expand their developmental learning. Now, agency, again, this will become very important, is a state of feeling. All right, so it's not a discrete emotion, but it's just sort of a state. I can do it, and you really get it from that little child walking. I can do it. where I feel in charge of myself. It encompasses both self-regulation, which is internal control, but also the experience of one's power within a system. I can have impact on others. I count in my family. I can make a difference. I can say, can we have peanut butter for lunch? And once in a while they say, sure. Right? Now, why agency is so important is that it demonstrates self-control, but it also demonstrates efficacy. And efficacy, we now know in the research, is a very critical quality for school success. It has to do with a feeling that I can both negotiate so that my desires and wants are important, but I also can work things out. I have some sense of, I can make this work. Okay? I don't want to get ahead of myself and tell you why it's important. I'll get to that. And the last attachment outcome is coherence and predictability. And we know that over time and with acquisition of language, the children learns to tell stories that reflect ongoing emotional security, even in the face of disruption. So with the parents' help, the child starts to translate that expectancies and strategies into stories. So remember when you had to go to the store and I missed you and I cried. Oh yeah, I remember that. And then I came home and remember what happened? And the child is really using that language capacity to start to remind themselves again of a coherence of story. I am cared for, as opposed to an incoherent story, which is they say they'll care for me, but then they don't come, or whatever it is. Now, we know that that becomes a very important quality, and it's the primary basis of the adult attachment research, the coherence of the stories. So, in summary, attachment forms an internal foundation as a neuropsychological regulatory system. How's that for a mouthful? That provides and facilitates new learning. That's what attachment is. A neuropsychological regulatory system that provides security and facilitates new learning. Attachment experience modulates or exaggerates genetic temperament and arousal intensity. So if you have a genotype, right, temperament that is easily overwhelmed, you may bring into your attachment system more vulnerability. Phenotype is the word that's used for the expression of genes, and we know that we are not doomed by our genotypes. Phenotype is far more important. That experience trumps endowment. So despite vulnerabilities, when the attachment system can work with those vulnerabilities and remain useful, the child is not damned to their genetics, right? So we know experience is more important. Oh dear, well, maybe we lost that one. It's just a point that what starts as interactive, however, becomes internal. So attachment experience, it contributes to how the internal brain and mind functions develop and sustain ongoing adaptation. So as soon as we start talking about attachment repair, we're talking about things that are in the child's mind, not only things that are in the interactions. And that's very, very important as we start looking at repair. It's not just what's in the family system, but it's as importantly what the child is carrying within his mind about the family system or any subsequent system he goes into. So secure attachment is a protective factor against developmental bumps, right? Attachment does not guarantee that life will be rosy. It simply says when life is not rosy, you can have something to fall back on, right? Insecure, disorganized, or disrupted attachment experiences create risk. And that's what's important. That will likely be expressed in deficits or as symptoms involving two things: self-care and self-functioning, and or relationship interactions. So is that clear for everyone? When you think about attachment disruptions, you're always thinking about symptoms or deficits in how I take care of myself and how I relate to others. All right, it's the I-we gyroscope, how I take care of myself, how I relate to others. Now, some children will have more deficits in one or the others. For some children, it's across both. So, we go back to that drawing. Risk involves impaired capacity that causes deficits or interact with genetic vulnerabilities to become symptoms. So when we talk about attachment repair, we're really not talking about fixing the original attachment, right? Sometimes clinicians will get referrals that say, help this child be attached, right? No, right? Or help this child bond. No, it's about help this child repair these deficits or symptoms that get in the way of their using their attachment, their current attachment partners or their new attachment partners, and also get in the way of their functioning. So that's why that list is so important. When we do attachment repair, we're working off that list, and we're trying to help those deficits to be less intrusive in the child's functioning so that they can have more adaptive new learning. All right, so what are the risks? I've described them. They're to self-care and they're to relating. I think this is one of the slides that's new, so send me if you want it. All right, so this is one of my favorites. What's the lack of regulatory care? If you go back to my chart, remember, these children, when they have too little attachment help, have the phenomena of not staying in that mid-range of arousal, but going off the chart. Right? Their arousal is not modulated. So the primary attachment symptom that we see is that arousal does not get modulated and regulated, and then the child must do all sorts of things to manage that painful experience. The other thing that's very important about this chart is that when arousal is too much, it is normative and adaptive to dissociate. Right? Dissociation is the mental equivalent of shock. And when your body or your mind is too distressed, it must check out. So a lot of times we see children with dissociative qualities. It's because the arousal is too great, no one can help them, and they protect themselves by checking out. Now, when they check out, what's the problem? What gets lost? No new learning. So this is exactly why these children feel like again and again and again, and each new relationship they go into, it's again and again, because they don't learn how to manage their arousal. They use dissociation as their primary adaptation, and they can't take in the new learning. Right? So without arousal modulation, and again, the reason I'm focusing on this is because it's a neuropsychological phenomena that's at the core of most disruption. The child experiences several things. One is that danger is too intense. Right? Danger stays activated. So many of us who work with these children know that very small surprises, even pleasant surprises, are perceived as dangerous changes. Dangerous events. Fear takes over, arousal is painful, often behaviors reflect internal fight and flight processes. And for many of these children, their attachment difficulties coexist with trauma experiences, which only exacerbates this. Secondly, relationship interactions become more disorganizing than organizing. So when my arousal is intense, and people talk to me about what's happening or what I should do, rather than that talk feeling soothing, it feels like bullets against my skin. Or as Charlie Brown has long told us, the adults sound like wah, 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 wah. Now that's a benevolent interpretation. It feels like we're talking at them and hurting them, which is why our interactions often inadvertently exacerbate their pain. And thirdly, I said that about dissociation is adaptive. The problem is that learning is compromised, and over time, dissociation, just like shock, takes a toll. The brain is a pattern-seeking, meaning-making machine. Now, we know that earlier learned attachment patterns are transferred to the world. So again, attachment difficulties are not just about with my mother or father. They become generalized to those who try to take care of me. So in my experience, rather than differentiate the difference between a mother and an uncle and a teacher and a cousin, I bring an undifferentiated sense that no one will help me, and these patterns are transferred to the world. The child experiences distress and expects too little help or harm. So the pattern-seeking, meaning-making machine is to confirm familiarity, because familiarity is a coping tool. The child's perceptions and energy are to be maintaining the familiar. We all like to know what's familiar. That's the importance of that quote. And often dragging us into this implicitly remembered attachment experience is their expression of that. So many of us have had the painful experience of being with a child and feeling like we're in an improv, only nobody gave us the script. Do you know that feeling? That all of a sudden things are going really bad and we can't figure out why or what to do. And there's an unconscious script getting played out that we're not a part of. And that is that child's familiar attachment script. The child is needing you. The child is wanting something from you. The child experiences distress, and they play out right before your eyes what their perception is that will happen. And often that perception is an incredibly difficult and cruel one, where they'll call you names, they'll tell you you won't help, you feel like you want to come in the room with a white flag saying, wait, wait. But that is that pattern-seeking, meaning-making phenomena that we know exists. Now, I just got warned I have 15 minutes, so I think I'm okay. I want to use disorganized attachment just as an example of this, because I think we'll see it in the 4 programs. Disorganized attachment patterns. Remember, this is the pattern that seems to lead to psychopathology in the research. By 3 and 5, we already see evidence of this pattern turning into disruptive and aggressive symptoms. What makes disorganized attachment so problematic is that it often involves a primary caretaker who provides comfort at the same time that the same person is causing distress. So that's why it's called the frightened frightening. The child feels frightened, right? That's what happens. The child feels frightened. Now, it's not always aggressive distress. We also see this pattern in parents who are severely depressed. A child looking at a flat face, that can be very frightening, a depressed face. To manage the confusion, the child constructs being the cause. And you'll see that coherence. Why is this happening? This has to make sense. So that the child then becomes aggressive and reactive. The child is now the frightening one. This turn of roles leaves the child disconnected from the parent and from others in moments of distress. And unaddressed disorganized attachment patterns predict later pathology in both personal and interpersonal functioning. So we can really look at that process and understand some of what our children are struggling with. Okay, now where did it go? All right, the other thing I want to tell you about this disorganized attachment is that, and this is a quote, severely insecure, abusive, inconsistent, and disorganized attachment relationships may well be detrimental for mentalization to survive as a dominant, predictive interpersonal strategy. What this means is that while mind reading is highly adaptive and protective within secure experiences, I spilled the milk. What is she thinking? Oh, she loves me. I remember that. All right? Very adaptive. It becomes potentially dangerous to know what is on another person's mind when that may represent harm for you. So in study after study, we see children who have been abused have very low capacity to, in neutral stories, read what's on another person's mind. Because if what's on the other person's mind is something dangerous, I'm going to hurt you, I'd rather not know. So as we listen to the repair, I think you'll see that often what we need to do is help these children open up their minds to the possibility of thinking differently, not only about themselves, but about us. Without this way of reassuring myself, I'm really bereft to the perils of the world. So what I want to do now, because I have 10 minutes, whew, okay. So you can hear where the risks are. What I'm going to do now is talk about clinical interventions that address underlying risk. And these are the things that I think are important. And I want you to listen to them. And then as we go into our 4 program models, listen to how these program models do or don't do these things. Listen to how these show up and see how ideas get activated into treatment repair. So the first is with primary repair, you're working with the emerging child-parent relationship. So Deena is going to talk about going in home to families where attachment is on the rocks. And how do you work to repair that attachment? You're building better expectancies. You're helping the child signal and be heard. You're supporting the parent's awareness of her own being parented. And the clinician is supplementing the parent-child system. Now, when attachment doesn't work well, then we're talking about secondary repair. So we're thinking about attachment outcomes. We're remembering that the repair has to be in the child. And in secondary repair, the clinician creates a reparative system that can potentially reactivate and remediate deficits. Right? Do you see that difference? So attachment repair always has to have 3 things. Rework relationship expectancies and strategies. It has to have repair essential self functions. And it has to have the ability to revise historical narratives so that they become useful and coherent. You can have a narrative. My mother didn't know how to take care of me. My mother didn't know how to do the parent job. That's a useful narrative. When narratives are, my mother really loved me, but she forgot to feed me, that's an incoherent narrative. So it has to have all 3 parts. Okay, the first tool I want us to think about is the importance of joining. Children with attachment difficulties do not expect others to help, or they expect to feel disorganized by help. So any attachment repair has to involve an attachment repairing partner. All right? Scott Harmon uses the term relational utility. Attachment repair has to have some relational utility. It has to be useful to the child, especially in moments of distress. If you ignore the moments of distress, you just missed your major attachment opportunity. So joining represents our state of mind. I want to go towards this child. That involves being there reliably to be hired. It involves joining and keeping time, providing the child with a sense of distress time and repair time. It involves naming and reading, and it involves constructing and practicing new behavioral patterns. Joining is all those things. We're always thinking about repair. So helpful in distress moments, instead of abandoning the child, we say, come back. And we try to get the child back to that mid-range arousal and then problem solve. That's what joining does. It brings the child back. Okay? I'm going to skip this one. I am going to read it. Do you know about mirror neurons? It's such interesting research. Mirror neurons were discovered about 10 years ago. If I scratched my head and I had a PET scan on, certain parts of my brain would light up. And if you're interested in me and you had a PET scan on, the same parts of your brain would light up, even though you didn't move your hand. It's about imitation. It's how we learn. Now, what's important about mirror neurons, it really confirms what we've known for a long time, that mirroring functioning is the best way of learning. The importance about mirror neurons is this second sentence. Mirror neurons allow us to grasp the minds of others not through conceptual reasoning, but through direct simulation, by feeling, not by thinking. So a lot of the attachment repair is going to involve how we help children engage in their feelings and our feelings. We just can't talk kids into a cognitive solution. Another thing we have to do is read behaviors for more than they appear, and that involves emotional interpretation. So I'm in a very crabby mood, so everyone just leave me alone. I hate everyone, hump, grump, puzzlement. Nobody recognizes my hints to smother me with affection. These children don't behave according to their internal need. They behave according to their internal fear. So we're always trying to repair that emotional interpretation. The third thing we're looking at is the making sense function. How do we help children learn to think about, which involves anticipating, interpreting, reflecting upon, and organizing both past and present experiences. We want to repair self-functions that permit ambiguity and disappointment. So I love this cartoon. We hate worms. You know, children can tolerate disappointment and ambiguity when they feel secure. They can't tolerate it when they feel insecure. So something as normative as being told you have to eat worms because you're a bird is very easy for secure children and can be devastating for attachment-disrupted children. They can't tolerate disappointment. So a lot of the work that we do with these children is helping them learn to interpret a minor disappointment as something that is tolerated rather than catastrophic. So when I say, no, you can't play with that right now, I'm not saying I hate you and I'm going to harm you. It's all in the interpretation. Next, we really want to pay, again, these are the common threads I want you to keep in mind, to how we support agency. Most of the interventions up till recently with these very disruptive and aggressive children have emphasized external control. Right? They've been very much about making children behave, making children follow the rules. What's the problem with that? The problem with external control is that if you don't repair internal control, the child continues to need external control. And if there's no external control, the child falls apart. So one of the shifts that we really see in research is that it's very important to let these children have a voice. It's very important to let these children negotiate. Now that goes against a lot of the parent advice books. Intuitively, adults want to impose control so to bring order and to make them comply, even when it's for their own safety. Contingency reinforcement is the way most of us parent. If you do this, then this will happen. But for it to work, it assumes several preconditions: self-control, intentionality, and relatedness. Now, I've just told you that this is what's absent in most attachment-disturbed children. So if we keep using that contingency reinforcement, we keep the kids stuck. Instead, children with attachment disruption need help gaining a genuine sense of their own agency and ability to have positive impact, to negotiate and be reciprocal. So again, listen as we go along to how these programs do that. I added this because we were having a conversation yesterday. Children with attachment disruptions need collaboration. They need their families to repair and build better connections, but they also need for us to build an attachment supportive community. Children with attachment disruptives are the most vulnerable and can least manage having diverging case plans from different intervening areas. They can't tolerate a school that sees them one way, a therapist who sees them another way, and a county worker who sees them the third. They need collaboration. They also need collaboration if they're to ever form a new experience with new families. Many of you work with children who are being adopted. And we know that in adoption, especially as the child gets older, that the attachment is not a primary experience, but what we call a secondary earned security. And they need that kind of collaborative support to help these families manage. And finally, I have to go back. Oh dear. Oh dear, I'm not going to let you go without my last one because it's so important. Oh no. Oh dear, you might have to miss the last one. I don't know how to, I know how to do this. Okay, so finally, end show. Oh, this is a Mac. This is a Mac. Oh, hello everyone, this is a Mac. All right, so the last one is there. And then I'm going to go this, and I'm going to go this. Oh, technology. Ah! The last one is a bird saying to the baby bird, bird's got to fly. And the point of that is that attachment is not the end point. Development is the end point. And so as we listen to these programs, I want you to remember that what we're trying to do is not repair attachment. We're working on repairing attachment outcomes that free up the child to develop as best as he can. Many of these children who have had early disruptive experiences are going to struggle through their middle childhood and adolescence with developmental tasks. What we're trying to do is help them struggle and not fall off the path. For many children, the best attachment repair is going to happen when they grow up and marry and have their own children. So we want to keep them developing skills, keep them developing hope, keep them developing an awareness of their own experience so that they can learn from it. So I'll stop. So, do we have time for questions? We have some time for questions. Okay. So, questions. So, we're going to take questions from in here, questions from the atrium, and questions from Greater Minnesota. All right. See, I did talk so fast. Questions, questions, questions. Oh, good. Here's a question.
I'm sorry, I didn't get the part about contingency reinforcement.
Okay,
Could you talk more about it,
sure,
please? With examples.
Contingency reinforcement is what we do and what most programs are based on. If you do this, then this will happen. If you don't eat your lunch, then you can't have dessert. If you throw this toy, then you get in trouble. So I have a lovely example from our program. We had a boy who came to our day treatment program. His mother was a crack addict. She had abandoned the children several times. The last time they were left in a park for about 27 hours and finally were picked up by the police. He came into the program, so obviously he had issues about sustenance. And shortly in, there was a honeymoon period, and he started to get really, really aroused. And he and the therapist were in a room alone, and he had a Rice Krispie bar. And he was very angry. He wanted the Rice Krispie bar. Something had happened at snack, and she handed it to him. She said, "Of course you can have a Rice Krispie bar." And then he got really, really upset, and he took the bar and he threw it up in the air. Now, it happened to be one of these rooms with those tile ceilings, and unfortunately, there was a tile out, and unfortunately, without any intention, the Rice Krispie bar went right into the tile. Right? Now, what would a contingency reinforcement response be? You lost your tile, you lost your tile, you lost your Rice Krispie bar, right? That's a very traditional response. Very appropriate for a child who has self-control, for a child who has intentionality, and for a child who has a connection with you. That child had none of those things. So the therapist, bless her, said what happened. So there she was reading him. She talked about the tile. He started to get frantic, and she said, "Wait, we'll get another." So they went and got another, and they went back in the room, and here you see the patterns, and he looked at her, And he was very aroused, and with some intention, he threw it back up. Right? So now he did it twice. Now again, you could go to contingency reinforcement because there was intentionality, but he was also a very, very distressed kid who had just come off, right, a life of not being fed and living in a park. So she said, we'll have to get another. Right? And he said, really? And she said, you're hungry. And my job is to make sure that you eat. And pretty soon you won't worry about that, and then we won't have to worry about losing Rice Krispie bars. You'll know that when you come here, you eat. Now, do you see the difference? We want these kids to get to contingency reinforcement. I mean, all it means is that I know the rules of society. I know how to stop myself. When I make a mistake, I know how to fix it. We want these kids to get to that, but that cannot be the start point. Because when it's the start point, they don't learn. What he would have experienced in his mind is, see, nobody ever feeds me. See, she's just like them. Right? Now, it's a distortion, but I hope you've gotten that feeling from these 4 presentations. That's the essence of the attachment disruption, is that these children do have internal distortions that match that first experience. And that's what we're trying to repair. That's a great question. Thank you. Any others? Yeah.
Okay, so using that example, you're talking about the goal, part of the treatment goal is to really create the ability to develop appropriate development, right?
That's right.
So as opposed to really repairing the attachment kind of relationship. But I'm just confused on that because like in the example that you gave, I'm looking at that type of interaction as an attachment repairing type of interaction.
It is.
Which would then allow,
that's right.
with enough of those, it would allow.
So when I say we're not repairing the attachment, I'm not going to say to this boy, oh, right, your mother didn't feed you, so let's talk about your mother, right? I'm not going to go back to the primary system. I'm not going to sit and talk to him about why he's worried about food because his mother didn't feed him. At that moment, which is hot, I'm going to start reworking expectancies and strategies. I'm going to say to him, pretty soon you'll know that there'll always be enough food and you won't get so upset. Pretty soon you'll be able to have snack and you'll be the boss of your body. There's your self-functions. And maybe at some point, way down the line, I may say to him, when you first came, you were so worried if we would take care of you because your mother had a hard time doing the mom job. Right? Now that might be way down the road though, because until the child hires me and learns to use me in a more developmentally adaptive way, that won't make sense.
So you are in the therapist-child relationship there. You really are kind of working on repaired attachment.
You're working
through that.
Well, now again, I'm going to be very particular with the language. You're working on repaired use of another. The attachment experience is in him. It's not like we erase that early learning. And we know this from foster care. We can take a child from a very abusive home and plant him in a new home. He doesn't say, yippee. He says, where's my mother? Because he is attached to that first parent and will always be. But what we're doing is we're saying functionally, how can I change so that you learn how to use me differently and more adaptively than in that first system? And here's the lovely catch. And when he goes back to his parent, he may relate more adaptively to her and help her be a better mother. So yes, I'm repairing the attachment functions at the same time that I'm respecting that that attachment experience is embedded in him. And I'm not erasing it. I'm not deleting it. I'm modifying the outcomes. Okay? Yes?
Anne, I want to say, first of all, I really appreciate your wonderful and optimistic or hopeful presentation. And my question is about, can all children or people do this development, or does it depend on a lot of factors like opportunity, timing, choice? I mean, I really don't know.
Well, I think we'll see from our 4 presenters, this is certainly not easy work, and this is not something that's going to happen in 1 or 2 or 6 or 8 visits to a therapist. For most children, because this is unconscious, highly patterned, right, repetitive learning, most children can do it with the patience of reparative partners, us. Now, again, the reparative partners, I say plural, because I don't think this is repair that has to be done by one person. What we're really doing, I realize I'm trying to get out of the light and I'm making noise on the microphone. What we're trying to do is we're saying there's this kind of experience that didn't work, and then there's that kind of experience that worked better. And our hope is that in time, the child will have the internal sense, this feels better than that. That's our hope. So attachment repair happens with therapists, it happens with parents, it happens with teachers, it happens with caseworkers, it happens with coaches. That's the attachment state of mind. We recognize that these children are vulnerable and need a little supplementing if they're to experience, one of the things that we often hear is get these kids a mentor. And so you get them on a team, right, with a mentor. And what happens the first time they go to the baseball game, right? They get aroused, they throw the bat, and they say blank you to the coach, right? And how long do they last on the team? Not very long. Now, if you have partners who can say, wait, don't be worried about not hitting. It's okay, lots of kids don't hit, and I'll help you. And you don't have to get scared and then be mad at me. I'll help you. Now we got an attachment state of mind going. So I hope we can be effective, and the 4 programs will tell us. However, we also know that this is very, very early disruption, and it is hard to repair. And when Krista talks about reactive attachment disorder, the most difficult, we'll see that this is not easy work. All right? Yes?
And in that context right there, could you also just say a couple things about the how difficult, it's sort of what can happen to the child, but the clinician piece of that.
Oh, lovely.
Can all clinicians,
Right. Excellent.
being able to join that child?
All right, so is this work that all clinicians can do? Maybe not. I mean, this work really requires the clinician to be comfortable with her own arousal. I use the word mutually regulating because we know these children are mutually dysregulating. Part of why it's so easy to impose controls is because they scare us. They disrupt us. They get us in vulnerable ways. And so it takes a clinician who is willing to be reflective, who is willing to be able to say, boy, that didn't go well, who's willing to come in after a contact and say, oh, that was terrible, I don't know what happened, and not feel like they're bad. It takes a willingness to be aware of your own feelings. It takes a willingness to say, some days I hate this kid, shocking, but you're not saying, I hate this kid. I hate this feeling that I have when I'm with such a dysregulating partner. How can I get this regulated? So lots of clinicians may find this work very hard. On the other hand, it's also very emotionally exhilarating. It's happening right with you. I have a message that I have to stop. So what we're going to do now is we're going to continue that question and listen to 4 programs. So as Carrie told you, we have 4 presenters who are all doing attachment-based work in the community. And we're starting with the least restrictive to the most restrictive. So the first speaker is Deena McMahon, and Deena has been an in-home therapist since 1981. So she's got stamina. She currently supervises 30 staff, and she travels all over the state. Deena is just remarkable for the breadth of her influence in training parents, teachers, judges, attorneys about the implications of attachment. And so she'll start, and then we'll have a break.
Hi, Mom. When you do in-home, I'll tell you the message about this workshop in the field couldn't be more than accurate. When we do in-home, we learn and give our lessons in the field, in the barn, in the basement, in the kitchen, in the garage, wherever our clients are. Sometimes that's because they're busy, and sometimes that's because they're hiding from us. But either way, that's where we head. And forgot to mention that I did start doing in-home in 1981, but I was only 9. The child prodigy, I was really a smart kid. I too can talk fast, so we'll see how this goes. You have a PowerPoint. I'm not going to use it because at 10 o'clock this morning I changed my mind what I was going to say. But I can get you a copy of this. The setting that we work with is in the home. Our client is the family. Whoever the caregiver for the relationship and the child is, that could be a adoptive family, that could be the foster family, that could be the birth family, that could be the kinship placement. It could be a combination of any of the above or below, however that is. Our kids that we work with are 0 to 21 years old, and they all present with some significant mental health problems. Many of them are also in the child protection system, as are your clients. And they're considered the deep-end kids, the kids that have multiple moves, dual diagnoses. They have had interrupted caregiving relationships, multiple experiences of loss and trauma. They're molested, they're hurt, they're starved. Those are the kids that we see. And the challenge for us, of course, is that we're working with their caregivers, many of whom have inflicted the harm. So I'm going to talk a little bit about the challenge of that. If these families could all get organized and agree once a week to get into a car to go see me in my office, they wouldn't be my client. So in the continuum of care, that's who we work with. Core components of attachment that we work with. First of all, recognizing that the therapist begins to teach attachment strategies to the parent. And the parallel process really is we care and empathize about the mom and the dad to role model for them that it's okay to have pleasure and experience with their child. We also work very much with the understanding of development of the child and attachment as dynamic and development in nature. Intergenerational patterns of attachment. We cannot do family systems work without having a good understanding of the parent experience from their childhood and who their relationships were. And we care about every single interaction with our client is going to have some component of engagement, attunement, and positive experience. I was wondering the other day, can we teach a parent to love their child? The answer is yes, because we know we can learn to love people. And so we certainly can teach it. That's what I think we're all in the business of doing, is teaching the moms and the dads and the caregivers to love their little kids and to find that relationship pleasurable rather than an obligation or a chore. Treatment goals and why in-home is effective. We provide structure. That's the first thing we're going to do. We're going to go into really multi-problem, chronic, chaotic families, and we're going to wrap our arms figuratively and sometimes not around this family system to get them organized in some fashion, because kids can't attach when they're dysregulated. We're going to do more and say less. And for some of us, that's hard. But because you went to college to learn to talk effectively, I'm going to challenge you, say less, do more with your clients. We're going to teach attunement. We're going to, everything the child does, say to the mom, look at that. Look at what she did. What do you think that means? Isn't that great that she can do that? Can you correctly interpret your child's emotional state through play, through talk, through smiles, through touch, through comfort, and through reframing? We're going to talk about and ensure and demonstrate safety. And when I talk about working with caregivers, the experience is I go in and I look at dad and I say, wow, no parent wants their kids in foster care. I am so sorry. I'm really sorry. This must be horrible for you. Because what I know is that dad is angry, defensive, and ashamed. And I need to demonstrate and role model empathy and attunement with him if I expect him to get it right with his kids. So it's going to start with me, the parallel process. And it's always, always family-centered. Rarely will you find one of our in-home staff doing primary work with just the child. The caregiver is going to be engaged and involved in those because we're not going to raise those kids. We really want the parent caregiver to do that. Challenges. You need to stay in shape physically if you're going to be in-home therapist because you need to outrun the family dog. That's rule number 1. Number 2 is you must always wear cat hair-resistant clothing. Always. Don't ever wear anything that needs to be dry cleaned. Number 3, you need to know how to manage chaos, yours and theirs. And some of us tend to be more high energy than others. I am more laid back, but some of my staff aren't. And so we need to understand how we behave when we're dysregulated. As Ann said, these clients invite us to get dysregulated. And we do a parallel process with them that isn't always healthy, but it sure is fun. So what we want to do is go in with a focus and a plan for our sessions so that we know that we can be effective, versus what our client family is going to do is invite us to solve the problem of the week. You're going to walk in and they're going to say, oh, and Johnny did this and this and this and this, and an hour and a half later, we haven't gotten to my plan. Well, think about therapist as alpha. I sort of go with that model because we need to do structure for these people to become regulated, and it starts with us. Another challenge for in-home is we never know who's going to be in the session. Changes from week to week. We always have our target client, and many of our children come in large sibling groups, so the whole sibling group is our client system, but mom might be there, dad might be there, grandma might be there, and that varies greatly, by the way, from culture to culture and community to community. Who gets involved in the Hmong families that we work with in St. Paul and Frogtown is very different than who gets involved in the Native American families on the reservation in Pine County. It just changes, and we need to go with that. Because the final challenge that I have here is cultural competence. We really, really need to care about cultural competence in the context of attachment repair because it looks different, and it should. Okay, case study. Dad. Dad's a recovering alcoholic, self-reportedly sober for 9 months. That's suspect. He has a 7, 5, and a 3-year-old. The oldest is a parentified child who's anxious, depressed, hypervigilant, and great little dad. We have a 5-year-old who's quiet, withdrawn, anxious, and really delayed socially, emotionally, motor skills, speech, language. We have a 3-year-old who is extremely defiant. Everything on her own terms. She refuses comfort except when she feels like she wants it. She won't share. She's demanding. She's mean. She's aggressive. She hurts others. She has severe tantrums, and she's diagnosed as red. These kids have witnessed domestic violence, prenatal exposure to drugs and alcohol, methamphetamine. They get supervised visits with mom twice a week. The referral says, can you help us figure out if dad can parent, and can you do some attachment repair in 3 sessions or less? Well, the answer is, of course, we do in-home. Sure we can. So I go to this family's house. Then I knock on the door. And the 7-year-old invites me in. Hi, my name is Susie. Would you like to come in? Can I get you some Kool-Aid? The 5-year-old is curled up on the dog bed with the dog in a fetal position, and the 3-year-old is standing in the middle of the kitchen table, on top of the table. Because I'm a trained professional observer, I recognize immediately that dad is not in charge. So I know that I need to provide, rule number 1, structure. That's going to be my job. Now, because I also parent 3 teenagers, I'm invited immediately to come in and take over. But I know that that's not helpful for dad. I have to get dad to take over. So my plan for this session is I brought my own blanket, put it in the middle of the living room floor, and we're going to get the kids to sit down on the floor with the dad. Because even a blanket is practice with limits and boundaries, isn't it? Well, that wasn't going to work because I wanted dad to have each child one at a time, sit on his lap, and he can rub their back, look at their face, see them smile, smile back, say, how was your week? Because they're not living together yet. But the minute the middle child got on dad's lap, the 3-year-old went over and kicked him in the back, and then the youngest child refused to get on dad's lap. So the plan is discarded quickly. 10 minutes into the session, I say, hey, I know, let's play puppy. Kids immediately get quiet. They like to play. That's their venue. Dad's looking more skeptical. But I am dad's attachment relationship at this moment. I'm helping him regulate. I'm sitting right next to dad. Never mind, at this point, all 3 kids, guess what, want to sit on my lap? No. Laps are for moms and dads, not for strangers that you do not know. So I'm saying, Dad, go with this. He's going, yeah, okay. We're going to be puppies, and Dad is the trainer. Okay? Dad's going to be the trainer, and puppies are so cute. Then Dad's starting to go with it. Look we have this puppy, brown and white spots. Oh, beautiful little puppy. Oh, look at the middle puppy. Oh, what a cute pink nose and a cute little tongue. Now, all 3 kids who have been very dysregulated, okay, they're on board. So that's what I do after the session. So they're excited and engaged. Guess what happens then? Dad can reach over and start to pet the puppies. Cute little puppy, cute little puppy. Scratch the puppy's ears. Oh, sweetie, what a cute little puppy. First session ends, kids decide therapy's fun. Dad's unsure. Second session, okay? Kid wants to play puppies. Cool. We know the game, we know the rules, because it's important to have rules, okay? So this time, we're going to practice some tricks. Dogs learn tricks. Sit, stay. That's a good thing, because this dad, and I'm not being disrespectful of children, believe me, these kids are out of control in a very controlled, intentional way, and dad's feeling completely overwhelmed. And so dad gets puppy treats in his pocket, which are jelly beans, or whatever the holiday that was on clearance at Target. And so he carries them in his pocket, and he says, bark. Oh, good puppy. Touches the puppy, scratches the puppy, plays with the puppy. Good eye contact, lots of physical contact. It's a very sweet thing. They're having a good time. They liked therapy that session. Third session. And we name the puppies, by the way, not their real name. Third session, kids discard their puppy name. They're starting to own their story. I'm really Susie. I'm really David. I'm really Johnny. I'm not Rover and Spot. Okay? We're getting closer to the heart of the matter. And they start to say things like, oh, when I was in the kennel, I was worried nobody would come and get me. Ooh, that's good. Oh, when I was in the kennel, my owners sometimes forgot to feed me. That's better. Now, these kids had been in a lot of therapy prior to my entering. Stonewalled the therapist. There would be no introspection about their earlier trauma. They weren't willing to personalize their experience. As soon as we're talking about a puppy in a kennel, they can tell us their story, which was very neat. So now Dad can say, oh, you know, I'm so glad the day I saw you in that kennel, I knew that you belonged in my house. I will know how to be a good parent to you. And now we can use the word parent instead of trainer. And that will never happen, and I will never forget to feed you, and always, always will take care of you. And the puppies are sitting on Dad's lap, of course, in a calm sort of way. And it's very sweet. So now what we have happen is it's reciprocal, okay? Because Dad is giving them treats, and the puppies have now learned to fetch, which means pick up their clothes, and do tricks, which means put their dishes in the dishwasher or the sink, because puppies are becoming more sophisticated helpers because dogs are good friends of human beings. Okay? So it's a reciprocal relationship experience for Dad and kids, and they're having a very good time. Now, one thing, Dad gets on board with me, not in presence of the children, and says, you know, I think I'm starting to catch on. This isn't about dogs. I said, you're right. You're right. But you know what? Tell me what happened in your life when you were a puppy. What kind of kennel experience did you have? And who was that that took care of your needs? So he gets it, and then he can identify some of his early experiences, and then know what he can do? He can say, I'm going to do it differently. I'm not going to do it the same way because that's not working for my kids, and it didn't work for me. And it's a very simple intervention, isn't it? You don't need a Ph.D. in anything other than creativity to know to be client-centered, to use yourself to do good attunement, to be very empathic about the work, because this is not simple work, and to care about the whole family system, because now the kids are coming in and they're starting to tell Dad their story, first person, what happened, and Dad can wrap his arms around them and care. Now, there's a lot of other work clearly to be done, and where I'm having Dad draw pictures and send pictures in the mail while they're still in foster care, having him make some calls. I'm having transitional objects in the children's pocket. Remember, when you put your hand in your pocket and you have this little smooth stone, think of me because you're in my heart, and that's how I think of you. So there's reciprocity, there's attunement, there's attachment. Isn't that nice? It's very sweet. It's not very psychotherapeutic if you think about, oh, what are our theories? But you know what? It completely is. It is so in keeping with the strategies and the foundation of what we think, and you all could do that. Thank you.
She underestimates herself, doesn't she? I mean, it's brilliant, right? It was just brilliant. And she makes, Deena makes it seem so organic because, in fact, she's embedded in theory. and everything that she does is informed. So I'm going to represent you and just make a couple of comments. Did you hear how her use of empathy and her use of positive regard? You know, if you come into these parents and start being negative, what happens? They get defensive. More importantly, they get aroused. Same language. Right? So she has an immediate sense of how do I reduce the parent's arousal so that they can join me and they can let me join her. They can join me and I can join them. They can become a part. We can work on this and we can start looking at the children. Now the second thing that I noticed right away is from the moment Deena got up, she used humor. Now, humor is something you have to be very careful about because humor can be hostile, but hers wasn't. It was very self-referential, and she created common minds. Talk about mind reading. You tell a joke, you say something funny, and the other person gets it, and you got mind sharing. So she used humor in lovely ways to help us join her and help the families join. The third thing that she really emphasized is structure. In a lot of the attachment literature, you'll see organized versus disorganized. So she's trying to organize. Again, it's a neuropsychological capacity to organize interactions so that they can be safe rather than chaotic and crazy. And the fourth thing that she really illustrated is that rather than fixing the situations, she supplemented functioning. Do you hear that? She really was supplementing his functioning. Now we have to ask you, did it end after 3 sessions? No. All right? So let's not be foolish. This is not work that dad says, oh, I get it. This isn't about puppies. And suddenly, you know, everything is clear. Because he, as well as his children, have very embedded learning that will take repetition, repetition, repetition. One of the mistakes that often happens with attachment repair work is that we think if we say it once, if we make that brilliant interpretation, everything should change. Right? But it doesn't happen. It takes real practice. So Deena really showed us how to activate that attachment difficulties in very, very powerful ways so that, again, the interactions were hot, but they weren't dangerously hot. Do you know what I mean by hot? Hot means they have amygdala involvement. The brain is involved. There's emotion, right? There's feelings, but it's not dangerous hot. You can't do this work if it gets dangerous hot because then the child has to disappear, as do the parents, right? Any other comments? Right? Very creative stuff. Very creative. Thank you. Lovely. All right, so now what I'm going to do is I'm going to anticipate the next. And Denise Lacher is at the Family Attachment Center, and she's going to present after the break. But if I introduce her, then we'll be ready to go. Denise is the director of the center, and she's also the co-author of a book, Connecting with Children Through Stories. So she'll be helping us see the next level of intervention where she's working with families and new families and their children around doing attachment repair. All right, thanks.
Okay, we're going to get started again. And I am Denise Lacher from the Family Attachment Center, and I have a quick announcement that will not count against my 15 minutes. But somebody has lost a set of keys with a tag that says Maplewood Community Center. So you won't be going home unless you come up here and get those from us. Okay. I'm going to start by talking about the core components of therapy at the Family Attachment Center. The key to repairing the attachment process is discovering the child's internal working model and challenging or shifting existing beliefs that they have about themselves, others, and relationships. And this is a process of Attunement, regulation, and repair. So what we're trying to do is shift what they're holding in their minds. So therapy is focused on facilitating the child or adolescent's ability to self-regulate or to accept regulation from their parent in a process of co-regulation. No parent is perfect, including myself, but the process of attunement and regulation or misattunement and repair leads to the formation of an internal working model. And in a secondary family, it is a reformation of that model or repairing of that model. And in our system, we are using attachment narratives, parent narratives, play, regulation techniques, attunement techniques, all of which I will not have enough time to talk about. So I'm going to try really focus on our narrative techniques. In looking at our model, we're considering three aspects. We are looking at attachment experiences, exposure to trauma, what significant life events or stressful life events have they experienced, and then developmental issues. And in the attachment sphere then, we are looking at what pattern or style do they have. And that's good information, but what we're really after is what is the belief? What does the child have in their mind about themselves and others? And those might be beliefs of, if I'm going to survive, I have to be in control of everyone all the time. You can't keep me safe. I can't rely on you. I can't trust you. I have to keep talking all the time, so you pay attention to me. So those are some of the beliefs that we are looking for. We're also, oops, I just skipped a page. And I'm not going to be able to cover all of these pages in the time I have. But when we're looking at trauma then, complex trauma or the trauma that occurs in a relationship, so multiple experiences of trauma in that relationship, can impair all the psychosocial systems. So there are problems in attachment, there are problems in affect regulation, both emotions and behavior, and in cognition, and in developmental issues, so disassociation that like Anne talked about in biology. So in our model, at the Family Attachment Center, we work with children and adolescents, and often I will say the word child, but I mean adolescent as well. So we work with children and adolescents that are aged 3 to 21 that have been exposed to complex trauma, and they have multiple impairment in many systems of functioning, including attachment. So the clients we work with have internalized a negative model about themselves and about relationships. And as Anne said, we work with clients who just didn't luck out in those first 5 years. And unlike Deena, we work with families that are able to get their kids in the car and come to a clinic. We work with birth families, foster families, pre-adoptive families, and adoptive families that are in a position to help repair their child's model and internalize new expectations and beliefs. So that's a key thing. These parents are in a position to help their child. We recognize the central role of parents in a child or adolescent's life, so we view parents as the experts in their child. They know a lot about that. They can attune to kids in ways that sometimes we cannot. We also engage in a parallel process with families. So we are attuning to parents, assisting them to attune and regulate their own children. Parents in our program are the primary agents of change. And families can opt for an intensive therapy program with a team of therapists, or they can opt for more traditional biweekly or weekly therapy sessions. Other treatment options might include individual family, reflective play therapy, attachment play, parenting techniques, and social skills groups. Again, the key to doing family attachment narrative therapy is discovering the child's model. And the key to discovering the model is listening to parents, because they know, they can articulate that model. So it's the therapist that needs to come alongside them and help them discover what that is. So the role of parents in our program is that they are experts in their child and the primary agents of change. Our role then is to come alongside them in a parallel process, listen to their stories, believe their stories, and understand what it's like to be with a child who is dysregulated most of the day, and help them discover what that unique model is through a process of empathetic inquiry. So we're asking lots and lots of questions, asking them to look underneath the behavior of their child and to discover what's the meaning of the behavior. Where is that coming from? What concept, what belief are they holding in their mind that's driving that behavior, so parents can begin to repair that. And also the role of the professional in this might be some education. Educating the parent about what is normal child development. They might have lost sight of that over the years. Factors that might affect attunement and deficits in brain function that can affect mood or activity or social development. In our narrative therapy, we have 4 narrative types, and this is helpful in structuring the narratives, but just to let you know, very seldom does it come across this way. Parents often combine claiming and trauma materials, or claiming and developmental materials, and claiming and successful child materials. As we discover the child's model, we can help the parents redefine the problem in terms of past attachment experiences, their past trauma, and their level of development. And this alters the parent's view of the child and reawakens empathy in them and allows them to better attune to their child and to get, again, underneath the behavior and figure that out so that we can develop narratives that might shift those internal beliefs. I'm going to kind of let you read your handouts rather than take time, because I've actually brought some parents along with me because they do the best work, and I want to take enough time to show you that. But claiming narratives are designed to increase the security of attachment, to convey the responsive care and protection that the child deserved. Now, we are not erasing the history of a child. We are not saying that this didn't happen or trying to replace it. We're just simply presenting an alternative. Trauma narratives help the child process the trauma, and we're trying to help them develop some coherence around their life story. Often trauma narratives are done in the third person, however, because this creates a zone of safety for the child. We're very sure that the material in the story is not re-traumatizing to the child, because the goal is to, as Anne said, hit that hot spot. We would call it a therapeutic window. We want enough emotion there so that the child is processing and doing the work, but not so much that they become dysregulated, because then therapy stops until things are regulated again. Developmental narratives are designed to teach the how-tos of life. So in some ways, we are supplementing how the child functions, teaching them emotional skills, cognitive skills, relationship skills. And successful child narratives teach values, morals, support conscious development. They can support cause and effect thinking, and they can be a lot of fun. These are also sometimes done in the third person because we do not want to trigger the child's defensiveness or shame. If you sit down and talk with a child about behavior, you know what happens. I don't have to tell you that, and that happens in our clinic as well. So these are fun stories about a girl in a galaxy far, far away who loved adventures, maybe a little too much, and then they go on from there. Okay. So I'm going to move on and show you. This is a trauma narrative. This is a 7-year-old girl who was adopted from China at the age of 10 months. She was abandoned at 2 months and placed in an orphanage until her adoption. She has severe separation anxiety, and her negative model tells her that she is unloved. The story that the parents are doing is from the perspective of the birth mother and conveys the love that she felt for her child. Now notice how the parents really they're painting a picture of what occurred so the child can really envision this and create and develop some coherence around her story. And they're also, if you look at their positioning, lots of face-to-face eye contact. They're touching her to reassure her. And that often occurs in stories where parents will hold their children, touch them, make eye contact, but not at the expense of regulation. So if the child does not want to do that, if the child wants to sit across the room, that wouldn't be we would rather have them sit closer, but again, we're looking at regulation and trying to keep the child regulated.
What the mom was just saying. can't just do that. I can't take my baby somewhere and let her in the woods and let wolves get her or something. So then he was like, well, tomorrow we're going to do it for you because the government people are coming and this is what you have to do. You have to do this. And the mom felt so pressured she didn't know what to do. There was nobody she could really talk to because she loved her baby. The last thing she wanted was for the baby to go away, but she also knew, well, she had to live. And it was like, what am I going to do? So she had no idea what to do. So this is what she did. So the night, about 2:30, 3 o'clock in the morning, she picked up Rose, bundled her up, and she dressed up really warm. She had a hat on. She put mittens on. She put big clothes on. And she took a big basket, one of those kind of folding laundry baskets that are really comfortable that they have a handle on. You know what I'm talking about? And he took her and she put her in this laundry basket. And she snuck out of the house and nobody knew about it. Not even her husband, not even the parents, nobody. And she started walking. And it was really far into the village because they lived kind of out in the country because she knew it would take her about probably 2 hours to get there by foot, but she didn't care. And so she walked with her baby, and every now and then Rose would kind of, you know, she'd stop every now and then because Rose would cry, and she'd comfort Rose and hold her face and maybe breastfeed her too because she was breastfeeding at that whole time to give Rose, the baby, some food. And then Rose would calm down and go to sleep again, and she'd put her in the thing again. And so she walked all the way to town, and when she got there, about 5:30 in the morning, it was really early in the morning before anybody was up. There were a few people every now and then walking by, but she walked until she found the police station. And because she was saying to herself, you know, I'm not going to let my baby die. I love my baby. And she had decided in her heart that it was too much pressure. She couldn't keep her. She just knew that because she had to think of her whole family. And she was so sad. It was like the thing that she wanted to do the most was to say, look, you know, she didn't know what to do. She was just not sure, but she knew she didn't want her baby to die. And she thought of her plan. And her plan was to take her to this police station because she thought, you know what, I'm going to put this baby in a place where somebody will find her. I'm not going to stick her out in the woods, or I'm not going to, you know, dump her anywhere. I want to know that if I can't take care of this baby who I love, that somebody else will. And so what she did was she put Rose on the doorstep of this police station and walked away. And where she walked across the street. And she walked to a place where she could sort of hide but watch Rose the whole time. And when she put Rose down, Rose started crying and crying and crying. And the mother didn't know what to do. She was just sobbing. She was over in the corner just crying because she knew that she'd made this decision and that she couldn't go get her at this point because then people would know, because it was also against the law to leave your child someplace. They couldn't make adoption plans in adoption at that time, or adoption plans for people at that time. It was a law against that. So the mom, you know, because then she could have made an adoption plan and that would have worked out great, but they didn't even have that. So she was stuck there. So this was her way of making an adoption plan. She knew that somebody would take care of Rose, but Rose was crying and crying and crying. And she wanted so much to go over there and comfort her and pick her up and hold her. And you know, babies, when they're just little, like when they're just a few months old, that's how they feel secure, is when they cry, the mom comes. They cry, and mom comes and feeds them or whatever. Well, mom didn't come, and Rose got redder and redder in the face and starting to be really upset, and the mom was crying, but she waited, and then pretty soon, somebody heard her cry on the street. They said, look, there's a baby. And all of a sudden there's a crowd, and everybody's looking at baby Rose, who's looking it up like, okay, who are all these people? And she's still crying. And then someone went into the police station and took the basket in. And then she went and they took her inside. So then the door closed, and Rose's mother stood there for a really, thought to herself that she'd done the right thing, because she knew that the situation that she had was so hard, and she had to make some decision. And the decision she made was to get her child to a place that was safe. And so
Okay. I think you got the gist of what she was trying to do with that story, is really present an alternate belief that this child was not unloved, even from the beginning. And this is the type of work that I get to see every day, and that's why I love my job. Those stories are not scripted for parents. We certainly talk about how they might construct stories, but they take these ideas and they go with it. And most of them go in there without scripts, without notes, and just talk from their heart. And that's what we really want parents to be able to do, is to determine that inner model, attune and regulate their child, and then help them feel safe and secure, help them process through past events, and develop a different narrative, kind of a restoring of their life. What we see clinically as far as outcomes, we often see change beliefs and expectations. So we go from, I need to control everyone all the time, to maybe parents can be helpful. Maybe I can let them be in control of this. Maybe if they love me when I set the barn on fire, they might keep me. Maybe I'm not so bad. And we see change beliefs in parents as well, because they are now focusing on something other than behavior. They are focusing underneath. And so they are saying, well, of course they're going to create chaos. That's where they came from. Or of course they're going to talk constantly, because if they don't, they're scared to death that I'm not going to pay attention and I'm going to forget them. So we're looking at that. Some of the challenges we face in therapy might be the parents' own stuff, because they have their own attachment history, they have their own attachment, their inner working model, and that might get in the way. Some of our parents have a trauma history as well. Sometimes they'll get back into focusing on behavior rather than focusing underneath. Sometimes the child will lapse into old behavior patterns when a new stress comes up, if the teacher goes on maternity leave, for example. But the biggest thing that can get in the way, the biggest challenge in our model, is an overactive therapist. If we don't stick with empathetic inquiry to bring out their expertise and help them attune and regulate and do the narratives, then they will put us in that expert chair, and they will come in saying, well, what do we do today? You're the expert. But if I empower the parents through questioning, through attuning to them by coming alongside them, then what happens in 2 to 3 days of therapy is they're coming in saying, well, Denise, we're going to do something about this. What do you think? Or they're coming in saying something like, no, that's not good. If I give an idea, that's not going to work. That's not a good idea. And then I know that we're on the right track with these particular parents. And in fact, just last week, I had a parent talk about how her son got nervous during a particular part of the narrative because he reaches over to scratch himself in a certain particular way. But you wouldn't know that because you can't attune to that. Yes, that's a successful outcome. There are challenges in doing research and trying to track. We do pre and post studies looking at behavior, but behavior is not a good representative of attachment repair. So you can track behavior, but it's not a good way to measure attachment. And it's also a challenge in a clinical setting to come up with a control group to do that kind of research. So that's family attachment narrative therapy in a walnut shell, very small. I wish I had more time, but I wanted to give you a flavor. Please contact us if you need more information or want more training.
So what Denise is saying, I have to apologize to the Greater Minnesota and Atrium people. Apparently you were getting a lot of plosives, because I talked too close into the microphone, so I'll try better. But what Denise is saying is true of everyone. Our hope is to give you a flavor, and if any of these programs particularly match your interests or your clients, call them up. We want to keep them busy. So here's what I heard in Denise's presentation, and wasn't that video just lovely? Did you watch the way that child was so locked in her eyes to her mother's story? So the first thing that Denise reminds us of is that beliefs. She used the word beliefs. And beliefs are actually a right hemisphere function. One of my favorite cartoons is a Doonesbury one, and they're talking about the presidential library, and the president says he's going to have a belief tank, and the reporter says, a belief tank, what's that? And he says, you know, a think tank without doubt. Beliefs are a right hemisphere function that has very little doubt. It's only when beliefs can move over to the other side and be reflected on that they become more flexible. So Denise's use of belief is very helpful to us because that's what many of these children have. They have deeply embedded beliefs that are not shaken by present interactions. So she's describing something that shakes those beliefs and moves them. She talked about parents become or are the experts. Remember my mutual regulation circle, the parent has the greater resources. So she's describing how the parent can join the child, supplement the child, and make these stories conscious. All right? Once they come into language, they become consciously mediated. They become shared. So the parent has the ability to make the past stories conscious and then start to form these new stories that also are conscious but tap into deeply unconscious or below the surface fears. She also talked about meaning making and how their approach tries to shift, not the story, but the meaning of the story. And that's what's changeable. You can't change the story, but you can change the perspective or the meaning of the story. And I think you'll hear in the other presenters how much we do that. You know, it's not that your mother didn't love you, it's that she didn't know how to do the mom job. That's a shift in the meaning, and she's really showing us that. The video was lovely because stories are so age appropriate for that child, right? That's an age where children love stories and they learn about the world through stories. And what the parents were able to do was several things. Did you notice the mother's lovely tone? How her tone was both soothing and then it got excited and it got distressed. And she really used tone so well at helping. And she did tone for the child. The child never said a word. I mean, she was just riveted to the story. The story said, this isn't only you. This is what happens to children sometimes. So she made it a little bit universal so the child wasn't so alone. She said, I can change the meaning of the story. That I can give you a way of remembering this pre-verbal story and give it new meaning. And that's what's so lovely. It gives it new meaning. And the last thing that was so clear is that just as the therapist gives the parent agency, there's that word again, the parent can give the child agency. So the hope is that as the child embraces the story, they also may change it. They may revise the story so it's useful to them. And again, coherence of narrative is not that it has a happy ending. The story doesn't have to end happily. It has to end cohesively. I hope that makes sense. It has to make sense inside, and that's what we're looking for. Now, during the break, one of the audience asked a critical question that I want to share here, and that's a lot of the children who have attachment difficulties and present as externalizers, the aggressive, disruptive kids, when we look at them, especially in school, they often have language scores lower than their performance scores. Now, this may be genetic. These may be children who are predisposed to have difficulty with language acquisition. But let's consider something else. It may also be, if we go back to Dr. Zeanah's presentation, you can explore if you're not secure. So you can't leave your right hemisphere arousal, vigilant self to come over to your left hemisphere, language reflective self. It may actually be evidence of a developmental lag and not just a predisposition difficulty. Many of these children don't use language. So then we as interveners have to do what that mother did. We have to help them know their stories, not just imagined stories, but immediate stories. How do we read for them what's happening and put it into language form so that they can start doing that narrative themselves. Okay? All right, I think I've covered everything. Oh, let me do one more and then I'm going to introduce Tom. Another audience member asked a question about helping a father, and as we talked, I was saying, help this dad know that that boy is hungry for you. This is a dad who didn't spend a lot of time with his child. A lot of attachment work is body-centered. Now, when we talk about body-centered, we don't mean, and Denise clarified that, we don't mean forcing children to sit on your lap or imposing your body on the child, but we do mean recognizing that children's memory is in their body before it's in their mind. So we use language like hungry, all right, because that's a body word, and it's evocative of that experience. So we're really thinking about the body experience, but not intruding on the body experience, but more describing it. All right, we could hear all of that in Denise's presentation. So now we move to the third. Take a deep breath. All right, got a lot for you. The third presenter is Tom Steinmetz from Washburn Child Guidance Center. And Tom is the program director there, and he's in charge of lots of things. But before he was program director, he was one of the co-creators of the day treatment program that I'm involved with and trying to demonstrate its effectiveness. He's also the father of Gabriel and Maeve, and he's going to tell us about what he's trying to do with day treatment. So again, the third level of intensity.
Oh boy. Anna's very kind, saying co-creator, because remember, oh, it's closed. Yeah. Remember that book that was real popular for a while, Everything I Need to Know I Learned in Kindergarten? I often think everything I need to know I learned from Gearity.
I lost it.
Except about.
But I'm getting very good.
Yeah.
I'm really getting this. Now, just a minute here.
The PowerPoint with the letters.
Oh,
all
the
zooming
DVD
around
player.
and
We didn't know how to get rid of the DVD player.
I think if you just click on the desktop. Here.
This?
Here, I think I got it.
Oh, you got it.
Let me try. If we just go like this. Oh, stop it.
Yep.
Yeah. There.
Okay.
All right. We're up and running. Yeah, and then go like this, right? All right. So, kids really do love stories, and Anne mentioned Gabriel and Maeve. My kids are 4 and 7 now, and I think if I could get up every day and the first thing that they say is, "Daddy, tell me a story. Daddy, tell me a story." If I sat and told them stories all day long, they would be very content. And as I've been doing that, and as they get older and keep asking for more and more stories, some of what I've realized is that my own reading as a child was embarrassingly deficient. So I've been going back and rereading some of these classics. We've been reading Wind in the Willows and learning about the water rat and the mole. And one of the stories that I read this winter that I've been trying to adapt and tell to the kids is Watership Down. And there's a great, does everybody know the story about Watership Down? Remember Hazel and Bigwig, right? So there's a warren, a group of rabbits. And one of the rabbits has this prophecy that they're all in great danger. And Hazel, who becomes their leader, leads this group of rabbits away from the warren and through the woods and through all this danger. And they try to establish a group, a community, what they call a warren, on their own. And they have these conflicts as they go along. But at one point as they're going through the woods, he says, since entering the wood, they had been in severe anxiety. Several were almost tharn. That is, in a state of staring glazed paralysis that comes over terrified or exhausted rabbits, so that they sit and watch their enemies, weasels or humans, approach to take their lives. What's he talking about here? Dissociation, right? It's a fantastic description. And that first phrase, the severe anxiety, all this attachment stuff that we're talking about, to me at least, it starts with anxiety, and we keep coming back to that over and over again. Bigwig, who's kind of the enforcer, like bruiser out of their group, right? He's always the first one who's ready to fight. He's talking about Ephrathah as this other Warren that they end up having to fight and get in these conflicts with. He says, I'm afraid I just lost my head, Hazel. I've been strung up all day thinking about this business at Ephrathah. It got me really on edge. When I feel like that, I have to do something, fight or run a risk. I thought if I could make that fox look like a fool, I wouldn't feel so worried about the other thing. What's more, it worked. I feel a lot better now. Bigwig shows an amazing amount of self-awareness that most of the kids that we work with typically don't show. They're not able to sort of narrate and describe their own experiences and perceptions of things in quite as much detail. But that's hyperarousal right there. And some of what I keep thinking about more and more with this stuff is Bruce Perry talks a lot about the hyperarousal dissociation continuum. More and more, I keep thinking about this as there's this core of fear and anxiety that's very much based in the early attachment experiences that gets manifested in different ways. For some kids, it comes out in more of an internalizing, dissociative kind of way. For some kids, it ends up coming out in more of a hyper-reactive, behavioral, externalizing kind of way. But it starts with that core fear and anxiety about relationships and those worries that are at the heart of it. So the kids that we're working with at Washburn's Day Treatment Program are young. These are 3-year-olds through 3rd graders who've already early in their life experienced very profound disruptions in their early caregiving or attachment relationships. About half of the preschoolers, this blows me away every time I look at this, about half of them are not living with their biological parents anymore. And they've mainly been removed due to abuse or neglect. So this is really the group of kids that we're talking about. And the big thing talking about those first 2 slides that we see over and over again is as kids experience repeated ongoing either traumatic events or disruptions in their care, those state experiences, those either whatever you want to call them, fight or flight, dissociative, hyper-aroused response tend to become traits. States become traits. So those immediate reactions that are adaptive in the moment tend to really become how the child lives and functions in the world. So I'm going to talk about a couple ideas really quick, but there's 3 stories that I want to tell to try to represent or describe what we do. The Watership Down is the first one, and then there's 2 cases that I want to talk about that I hope will give a sense of how we try to apply this stuff. Okay. This thing about perceptions has come up a lot, so I'm going to just mention this. A lot of times what tends to happen with kids is that these moments of feeling afraid or scared become very globalized and broad and really become how they tend to perceive what's happening to them in the moment, but also what they really expect is going to happen. So adults are scary and dangerous. If they get close, they'll hurt you. Some of this explains why when a new child comes into the room or when a new intern or therapist starts, they'll sometimes come up to a child who's kind of twitchy or who's new, and they'll put a hand on their shoulder and say, hey, how are you doing? And how does the kid react? Get off of me! Why are you hitting me? These very intense reactions because their expectation is so powerful that they're going to get hurt. All right. So this is the one thing that it kind of all comes down to for me. And this is a lot of what Ann has talked about and the other speakers have talked about is that it's not a causal, linear kind of process. All of this stuff is back and forth. It's all very dynamic and interactive, and it's all very relationship-based. So what we tend to see happen is that these state experiences that the child has, where they get overwhelmed with their own feelings or their own fear, become traits, right? They become an entrenched pattern, okay? What tends to happen, though, is that as that starts to become a trait, they then start to create that in the environment around them, right? And that's where you see those disruptions start to happen. We've talked a lot about how external experiences and external relationships start to impact the child's own internal state. But then as that starts to become more of their pattern, they tend to project it out, and it really creates this kind of cycle. Okay. So I think the core of what we're talking about doing, and I want to talk about 2 examples that talk about how to do the same kind of process or the same kind of idea, but in 2 very different ways. A lot of this, what this is about, is trying to watch the patterns and observe what's going on in the child's, not just their behavior, but in how they tend to be perceiving situations and how they tend to be experiencing relationships. First with you, either as their therapist or their teacher, and with other kids in a group if you're working within a group setting, or individually. Watching those things and then trying to get at what's underneath driving that. And then as Ann was just talking about, how to bring that to the surface and create these new repeated experiences that things can be different. Okay. So the first story that I want to tell you about is a boy that I worked with several years ago who, same stories that we've been talking about, parental mental illness and drug abuse, and mom was in and out of the picture and all this stuff. Dad had not been around early on. When he first came to us, he had gotten suspended just over and over again. He was about 7 when he first came. And there were several siblings that were scattered all around. He was living with a couple other siblings and his dad. Dad had really pulled it together, was working 3rd shift, but the problem was that this boy, who I'll just call Bill, kept getting kicked out of school. And Dad kept having to come to school when he was trying to sleep and pick him up. Now, the first thing that we've seen a lot of is that we can do all kinds of work with kids individually, but if the external environment is not supportive and the external relationships and supports aren't there, it can kind of all come crashing down. So a lot of what we did, a lot of the work in this case is helping to take what we're doing and then find other partners in the community where the kid's going to be longer term, and helping to finesse that so the child winds up with other people who are going to be sympathetic or who are going to be able to respond in similar ways. So some of what we ended up doing with Bill was first helping him move to a new school setting. He wound up with a brilliant special ed teacher in Minneapolis named Krista Ward, who was phenomenal with him. He started on a medication trial, which was incredibly helpful to manage some of his impulsive symptoms. And we're humming along, and I'm thinking, this is going great. I'm feeling really good about myself as a therapist. And we had a couple events where he had gotten in trouble again at school. He missed a dose of medication. I don't even remember what happened. But all of a sudden after that, he just tanked. And this was after he had been coming to us for 4 or 5 months. And every day, over and over again, this kid was kicking my ass. I'll just say it. He was just pounding on me every day, fighting, hitting, biting, kicking, screaming, the whole 9 yards. And I'm going through this thinking, what have I done? You know, I'm thinking we've got the school in line, we've got the medication in line, we've got all this, it's going great, we're on track, and yet this keeps happening. And every day I kept trying to get at, Bill, what's going on? Something has just changed. I don't get it. I don't get it. This kept happening over and over again, and he wasn't able to talk about it. And when I talked about it with Dad, we weren't able to really get at what was going on. So we kept trying to put these pieces together. Is it something at school? Is it something at home? Is it something that's happening in the group? Nothing. And then after one particularly difficult and humiliating day of being kicked on and spit on and all that stuff, I ended up having to drive him home because he couldn't ride on the bus. And as we were driving home, he said, my dad's been telling me that if I don't shape up, he's going to have to get rid of me. And so my heart starts racing, and I'm driving home thinking, holy cow, what's going on with this? And I said, Bill, we need to talk about this when we get you home. And I said, can you tell me again, how's your dad been saying this? What did he say to you? And he repeated it again, and I was really scared. I was scared because I like this dad a lot, and I was worried how he was going to respond to this. I was scared that I didn't know what was going to happen if I brought this up. But we got to his home and went inside, and his dad was a bit upset and worried because he had been flipping out again. And we got to the home and sat down, and I always referred to him as Mr. I'll just call him Mr. Bill so we don't have to use last names, but to the dad, said, when we were driving home today, said, I know that Bill really, really loves you and respects you, and when he's with you, you help to settle him, right? And today when we were driving home, he said that you had been telling him that if he keeps acting up like this, he's going to have to leave. And I said, I think that because he loves you so much, that's making him really, really scared. It's making him terrified that he's going to lose you. And I think that might be some of what's going on with his behavior. And so first of it was just saying, is this what you've been saying to him? And Dad, to his credit, was able to say, he said, yeah, I'm so worried that he's not going to do well and that he's going to keep getting kicked out of school. And I didn't know what else to say to him. So I thought if I told him that he needed to shape up, that fear would kind of help him stay in line. And instead, it was coming from a good place from Dad, but what that was really doing was making him so terrified that he kept acting out in this way. So the next part of the conversation then was talking with Dad and saying, I get what you're talking about, but if Bill is going to keep making progress, he has to know that you're going to be there for him. And we talked about, if you really feel like you can't take care of him, let's talk about that. But if that's not what you want to do, then we need to come up with a different way of talking about this with him. So Dad was able to be very reassuring to Bill, let him know that he was not going to do that, and then we were able to come up with a different plan. And that was one of those times where 2 months of living hell really just disappeared once Bill really felt and believed that story was true, the story that we were able to talk about with he and Dad and I together. And after that, he settled down. Somebody asked earlier, can these kids really be healed? Does this stuff ever really go away? I think that Bill will continue to have some of these kind of cycles all through his life, and at least through his adolescence. But the more that they have a foundation of knowing that when if they can trust adults to talk to or do some of these other things, the better off that they're going to be. Okay, so a lot of this is identifying some of those, whatever those unconscious patterns are or those underlying feelings, and then how to bring them to the surface and help them be resolved. So the big thing that we've talked about in the shift that we've really made in our day treatment program that Anne's been very instrumental with is moving away from, if you look at school programs or a lot of the descriptors about things, it emphasizes the behavior, that they're kids with serious emotional and behavioral problems, or they're severely emotionally and behaviorally disturbed kids. And we've really looked at it more as working with children who've experienced profound early attachment disruptions and early complex trauma. And the thing that we keep coming back to over and over again is that core experience of fear and anxiety that's underneath that. And that a big part of treatment is attending to that and trying not to get distracted or too caught up or too reactive to the chaotic, difficult, challenging behavior that goes on, but get at the underlying emotion and helping to resolve that. So one last quote from Watership Down. This is talking about Hazel, and toward the end of the book, how he had kind of become this leader of this group of rabbits. And what they said was, he was simply the one through whom a strong feeling latent throughout the warren had come to the surface. And to me, this describes the therapeutic process as well as anything else. A lot of this is about helping this stuff come to the surface. So one other, 2 minutes. I was looking for the time cards in the back. I'll keep this one really, really short. A similar thing, but a very different presentation. A girl that I worked with really, really early on when I was in day treatment and just had absolutely no idea what I was doing, had been really severely traumatized, prostituted by her dad as a 3- and 4-year-old, and she nearly lived in a dissociative state. I mean, I could see her sitting in the group and constantly just being gone, and then she'd come back momentarily and she'd be gone again. And luckily, again, fabulous teacher, an incredible foster family that she was with. She ended up being adoptive, but we spent a few months in therapy were the only work that we did, it was very, very much nonverbal. But the work was all about her simply being able to be with me without having to dissociate. So we spent months of work. We would leave the room together. She couldn't go upstairs to my office to do an individual session. She was so terrified that I was going to harm her in some way. So we spent a few months, literally the treatment was walking across the hall, and I would try to narrate to her and say, Tina, how are you feeling right now? Are you still with me? Can you try to stay with me? And we would keep going through that process, and she could communicate non-verbally and say, do you feel safe enough to go into this other room? And for a while, it was just head nods, no, no, no. But then eventually, we were able to get further and further away from the group and the other kids, and she was able to start saying with her head more, yes, I can do that, or yes, I feel safe doing that. And this months of work ended up culminating in her finally being able to leave the room with me and share some stories about how she was getting ready to be adopted by this family. We never explicitly talked about the trauma that was involved, but I'll say one last thing here. The thing that sort of sunk in and made me know that this had reached her in some ways is toward the end of her treatment, we were out on the playground together, and she just spontaneously walked up and reached over and held my hand for about 30 seconds, and then just looked at me, let go, and moved away. So we've talked a lot about talking too much. I'm talking too much. I'm going to stop now, and thank you.
Thank you, Tom. You know, I think the hardest part for you of today is that I wish we didn't have to stop. You can see how rich these stories are. And I love your quotes. So let me comment again, as representing you, what I hear in Tom's presentation. The first thing that stands out is that core of anxiety and fear. Part of why Washburn went to working with children 3 to 3rd grade is because those of you who are working with these children in older ages know that time does not serve them well, and that these symptoms of fear and anxiety crust over. They turn it around and become more defended, aggressive, and difficult. And at least in a 3 or 4 or 5-year-old, you can still see those glimmers of fear and anxiety. With older children, you have to trust it. You have to know it's there. But it's really hard to see. Tom's story certainly reinforces that need for collaboration. You do not need to do this work alone. I would even say you cannot do this work alone. If you don't have collaborative teachers, if you don't have sensitive CPS workers, if you don't have, available partners, it's very, very difficult, and you really captured that. I love the story about Bill, how Tom said he was getting the pieces all fit together. Doesn't that sound just so neat and tidy? And then it fell apart. And that happens again and again and again. It reinforces that idea of practice. What's lovely with Tom's example of Bill is that he sees the moment. The repair is not in the past stories. The repair is right in front of you, right? Right in every interaction, there is the possibility of repair. And he really was able to seize that moment with Bill and read the present, and helps Bill's father read the present. And that's where the repair is. You don't have to go back. You don't have to be detectives, looking for the past story. It's going to be right there for you. Tom also makes the point about, the foundation. When the foundation is shaky, repair is possible, but it's very, very important for us to realize risks don't go away. They are mediated by protective factors. So again, we're not erasing the past, we're not erasing the risk. What we're trying to do is repair essential functions so that those become protective factors against these inevitable bumps. We often wonder, what happens when a child leaves our treatment? And it's possible that 2 years, 4 years, 6 years, 8 years down the line, they'll struggle again. But what we're hoping is that they can pull those protective experiences to right themselves. And finally, 2 thoughts. Tom said something very profound that we should have started with. And it goes to your question of can everyone do this work. The primary quality for doing this kind of work is a willingness to let the children teach you how to do it. All right? That's the primary requirement if you want to do this work. When Tom said, I didn't know what I was doing, most of the time, and after 32 years of practice, when I'm with some of these children, I don't know what I'm doing. And I have to wait, and the child will teach me how to do the work. One final thought, and then, because this connects with Krista's presentation, the one thing we know in the developmental research about aggressive and disruptive children is we should not aggregate them. We're not supposed to put them in groups. All right, 20 years of research, we know we're not supposed to put them in groups. So why are we seeing these children in groups? In part, we're seeing them in groups, and residential treatment will illustrate this as well, because they don't have any other groups. This is the group that they're part of. So we have to be very, very careful to make sure that the groups that we put them in do not collapse into chaos, but actually stay positive and reparative groups. We have to work very hard to not let these groups become destructive, but rather reparative. And so as we move into this last presentation, let's really think about the challenges of group treatment. So our final presenter is Krista Nelson, and Krista is the program coordinator of Wilder's Reactive Attachment Center. Krista and I started on this journey of taking research into practice around the same time, and we've had conversations over the years as we've each stumbled into trying to make sense of this. Krista, in addition to coordinating this research and practice model, is also in community practice where she does individual work, parent training, parent education, teacher and clinician training, and as she says, tries to make all this real. So, Krista. Do you know how to do this? The last technical challenge. See, somehow it doesn't show up, so.
Can you go into maybe exit mode?
Oh, exit.
Escape.
Escape.
Yes. Ah. Escape. Okay. Are you staying right here? Kind of help me co-regulate to get close. Okay. Oh, I see my husband laughing at me now as a computer guy. Okay. Oh, what did I do? I exited?
You can click OK.
Okay. This is very nice, Carrie. Thank you. I feel much calmer. Okay. That's it. Oh, well, the other one we don't need. Good afternoon. It is good to be here. There are joys and challenges of going last in this illustrious panel of colleagues. It's been a rich learning afternoon for me, so I hope it has been for you as well. I want to start with greetings from Holcomb, Spencer, Bush Treatment Center, the people who I'm going to be talking about today in terms of their clinical work. I'm going to be their voice piece. They're the ones who are doing the day-to-day work with children. And I'll start also by sharing 2 dilemmas. Joys and dilemmas, right? Always working with children. Get ready for this. But one dilemma we have is that we have this impossibly long title to what we do, the Center for Children with Reactive Attachment Disorder. Let me just clarify, there is no bricks and mortar center. We do not have a separate place where we put all the attachment disordered children. We thought that might be a good idea very briefly. And we changed that, and in fact have This process has been embedding that which we know about attachment research and the little tiny bit of what's out there in terms of attachment treatment efficacy into practice. And we really created this approach throughout our whole milieu. So the center is embedded in, let me clarify that, and reactive attachment disorder. Increasingly, we have conversations as to, okay, that's the diagnosis, but what does it really tell us? And does it really describe who this child is? So I also want to say to you is that we point out we have a cluster of children with that diagnosis, but sometimes we're talking about kids who don't have that diagnosis, and they almost always have more. We're dealing with kids with a whole mosaic of issues. Increasingly, I think in residential treatment, we're working with emerging mental illness on top of attachment impairments, so that's why they are with us. Okay, those are our paradoxes. The other is that we're trying to help a child learn how to live in family by removing them from family. What's that? How is it that we are actually audaciously saying we're building family life skills in a residential treatment facility? But I want to share some illustrations and stories today that say that the point at which parents painfully place children in residential treatment is at the point where they really not just saying, I'm going to kill the kid. They can think about it actively, and this child perhaps has verbally frequently said, I'm going to kill you. So we're talking about a very toxic environment in the home that we think at this point is going to make that fragile attachment come apart. So I was thinking today, maybe it's like a big timeout for the whole family. So everybody gets to calm down, and then we can come back together again and try to rebuild that sense of family. So that's how we live that paradox. Okay, cases, make it real. I'm going to try to talk briefly and quickly about two young persons' journey through our program. One I'll call, and this is a composite of many kids' stories so I can protect their confidentiality. Kevin, age 8. I often sit at the phone and get the phone call from the parent the first time who's heard about our center. You have a center, can you take my kid? So I hear the frustration in that parent's voice. This child has been aggressive to me, says grandmother. He doesn't seem to, he's perfect in school, he can hold it together, but when he comes home, he's baiting me, he's vicious, he's hitting me, and it all seems to be directed at me. My husband, he doesn't get it nearly as much. I get it. He doesn't seem to be able to deal with anything. A kid looks at him funny, cross-eyed, and he loses it and starts to punch out. Very low frustration tolerance. Peer relationships, this boy has no friends. Thank you, Ann, for that comment. Our kids do not have community. They've alienated friends, they boss everybody else around, or they have no clue about how to socially engage, so they're the ones sitting isolated on the playground. Early history of neglect. Bruce Perry and others work on neurologically what has happened to a child in the neglect experience is our reality. We work with so many children who part of their deficits are understood by the neglect experience. And there are multiple moves. So caregiver to caregiver to caregiver sets that precedent of not having an attachment partner at critical windows of their developmental process that allowed them to do skills of self-regulating, everything we've heard today. So we know they have that early history. In addition to that, we have children who have witnessed violence and witnessed violence to their caregiver. Kevin saw his mother beat repeatedly by mother's boyfriend. And what did he do with those experiences? He internalized it inside, and now he's becoming a very aggressive young boy himself. Diagnosis again, ADHD, bipolar. This boy had bipolar disorder. You know, when you look at the old charts, I remember looking at them, RAD, bipolar, ADHD, different, right? In our experience, we're seeing kids with the whole mosaic of things. We have a boy with attachment, significant problems, but he also has organic issues that affect his mood, and they coexist. And so our caregiver, exhausted, fearful. This is a bad kid. I don't really want to say that, says Grandma, but I feel it in every bone of my body. We work with young kids, age 5 to 18, and an adolescent, just to give you another window of a young lady I'll call Tasha, who's age 16, adopted from Russia. But we work with a lot of kids from the Eastern European orphanages. This is a girl who witnessed frequent sexual activity. Her mother was a prostitute until her mother's death, where she was placed in orphanage, had to be tough in that orphanage environment to survive. And then we have a good, well-meaning Minnesotan parent who's going to adopt this kid and take him across the world to be the daughter she never had. Oh. This is a very well-meaning mother, but she has got quite a task ahead of her in trying to do a patch repair with a child who his internal working model is of constant fear and fight. And so she's done very well, but in adolescence, we have the body changes of that girl. This is a very attractive young lady, and she is able to whip that charm around with those boys like no nothing. And that power infuses her with that reviewed kind of hypersexuality. Maybe she's the bigwig of her warren, if you will. And as that gets going, all the work that Mom was doing, building up that trusting relationship, seemed to crash as she hit 14. And 14's hard anyway. So now we're having violence, we're having sassing, we're having running, we're having sexual behavior, boys coming into the house. Mom feels like she's lost total control of the home, and she has. And then the in-home worker, not trained by Deena, comes in and sees this situation and says, we have a differential here. We have a child who is parenting the parent. They're equal in the hierarchy and is starting to recommend parent training. So at that point, we looked at residential treatment for this girl because she was so in crisis that outpatient therapy was really doing nothing to alleviate that escalation of becoming unglued. How do we know kids are ready for residential treatment? How will we know removing them from home is going to make a lasting impact on their behavior? How do we make sense of these issues to determine the treatment direction? What would you do with Tasha? What would you do with Kevin? And how does attachment theory and research increase our capacity to stabilize or even understand these youth? Again, I wanted to greet my team. Here we are, 58 youth, 5 to 18 in 7 group living environments. 90% of our children have trauma exposure. They're in their 4th out-of-home placement on average. And yet, here's this, 76% return to their community or their family at discharged. In our center, which we pull out the kids who have this early life experience, who have the diagnosis, or who have a significant score on the RADQ, and I can talk about that later. We have about 126 youth we've worked with over the last 5 years, and then our goal is to track their therapy progress and see what works with kids like this. So what are we trying to do? Oh, I have to throw some pictures in here. Institutions and families, do they mix? Are we that fortress on the hill? Are we that locked facility? You know we're not. I was interviewing a student for an MSW placement earlier today, and she said, are you guys locked? And the staff person said, well, we're locked on the outside, meaning the community can't just waltz in. We have to make sure this is a safe place for kids. And we're in Frogtown and St. Paul. It's not always so safe. But the kids can go. And somewhere quickly in our work with them, they have to buy into our program and begin to invest themselves. Because if they're running all the time, if they are totally out of control, that's probably our variable that we need to get them to a facility that will really contain them. But our level of containment is more extreme in the level of program that we offer. It is a thorough group living experience. So those are the kids that can best survive with us. Good milieu therapy shares the same qualities, I think, that we've been hearing about all through the series of what is attuned and proactive care from a caregiver to a child. And our goal for all of our kids, I think, regardless of diagnosis, would be to enhance their ability to be in secure attachment relationships. So we want to craft this environment that surrounds a child, that gives this child the increasing sense of, I can use adults when I need them. I can take them in for comfort. I can accept limits from them when I'm going too far. I can explore. I can pull back and melt down. And these people around me are consistently providing me with those functions until I can use them myself. And then get out of our center and go home and practice those things in the environment. A couple pictures. So here we are in the community. We can't just do that with our 4 walls. We have to get out, and we're hiking, we're camping. We've got a playground, which all kinds of hide-and-seek attachment games are going down in that playground structure. We have a group living environment that we change. Those cubicles you see in the picture are different kind of developmental play tasks. We'll have a kitchen, we'll have a truck station, we'll have various things that just kind of replicate family life and let kids really get in there and play. A lot of our work is allowing children to regress. It's developmental catch-up. So we want to invite that little kid part of even that tough 16-year-old Tasha to emerge and start playing with dolls and trucks if she chooses to, or make up her hair or whatever it might be her medium as an adolescent. This is the Children's Center here. We have the benefit of artists who come in from the community in a free arts program who work with the kids around designing this gorgeous mural or do drumming or dancing or anything that allows some creative expression to be able to move their bodies in different ways. And this is a child's bedroom. Transitional objects have been referred to. We think about that all the time, of letting kids, they come in with a garbage bag of stuff, but if they have a teddy bear, let's bring it from home. We put pictures up on the wall that children get to personalize their environments. We work very strongly to not have this place be an institution, but a breathing, living place that says, I'm home to the child. So, RTC retains, it's an intensive intervention. It's not for everyone, but we want to pinpoint those kids who cannot progress with their developmental steps unless they have this all-encompassing environment that gives them containment, safety, structure, because they're internally terrorized, like you've heard from all of us today, and who just cannot cope with those developmental demands outside until they do some developmental repair in our environment. Okay, how am I doing? 2 minutes? No! All right. Well, darn it. Okay, they're better. They went home. No. Oh. Well, okay, our treatment model has milieu, it has individual therapy, and it has family therapy. Think of that as a triangle. They work together tightly. Milieu is the heart of residential treatment. It replicates those day-to-day life experiences where we're structure, nurture, engaging, challenging kids. And we're using all of attachment literature to make that real for kids. And I wish I could tell you more stories about how our staff do that. But we offer tours, come see. I mean, just something like the other day, Tasha was nervous about something. So she went up to her direct care staff, and from the staff's position, she laced her hands around her in this really contorted, uncomfortable way. How would you like a kid coming up to you, our little gangster kid, lacing her hands around her like an octopus? And what she started to do was tap on her like this. And the staff in our staff meeting, this is another critical part of the training, you have to have good staff meetings so staff can talk about, I hate it when she does this. It makes me crazy. But then we could translate her behavior to say she was like that little kid pulling at the coattails saying, I'm scared to death. Help me. And so that was the signal that she had developed with the staff. And then we use a lot of what's called parts language in our world, of talking about her little kid part that's scared to death, and I'm seeing that right now. But do you think, 1 minute, she could show us in her 16-year-old voice, and now we start to try to developmentally pull that kid from little to big and back and forth again to be able to talk about what's going on, so now we have some language. Because we're working all the time on these processes of mentalization, making it, understanding it, saying out loud for the child, and then putting it into words so that they feel mirrored, reflected, that their reality is coming back to them from an adult, and then let's do it, let's go. Lots of us language to get it moving again. Individual therapy, multisensory, try to use all the arts. It's being with and feeling with a child in terms of making that change process happen. Again, less talk, all kinds of play, drama, felt security. And it's really dancing lessons. We're talking about engaging a child and shifting the way they dance. In the individual therapy, that therapist is working hard to be able to use some multisensory tools like Play-Doh, like Barbies, like tools like motor oil, whatever you need to kind of give that child that internal sense of, it feels good to be with this person. I'm enjoying myself. These are kids who don't know how to play worth a darn. They're ordering everybody around. Stop, don't talk to me. Let's be together. And that's the first steps. And eventually then we're using some other tools like timeline, suffering skin. These are storytelling methods to be able to help a kid begin to do much of what we've heard, tell and understand their story in a different way, until they're actually able to do problem solving like an adolescent sitting at the table, figuring out where they're going next. Family therapy, I think we've already heard it from our colleagues. We do it very similarly. And that's our greatest challenge, of how do we really join with a parent, sometime who lives in northern Minnesota or right across town, but has so many survival issues that to get us going on the same page, to get that child back into the community, is what we have to start from day one about. We talk about discharge from day one. respectfully with the family. So I only have a minute left. I have to say stop, in fact. Okay, well, Well, I'll stop with Maya, because I love to stop with her. I've learned that people will never forget what you said. They'll never forget what you did, but they will never forget how you made them feel. So with that, we urge you to go forth and be encouraged to try attachment-focused work in the work you do.
It's just lovely. And again, you could see we could spend time. So very quickly, just a couple of comments. It's a very innovative and different way of thinking about residential treatment. Very innovative. I want to comment to group living, because the trajectory for reactive attachment disorder is reactive attachment disorder to conduct disorder to antisocial personality disorder. All right, that's the research trajectory. So what Krista is talking about is not only helping these children tolerate family life, but social group life. It's really working on that idea of social membership, which is an outcome of attachment, a sense that I belong to the club. She said these children can't play. There's such a hyper-arousal of the attachment system that subsequent developmental capacities are impacted, and play is one of those capacities. So arousal stays so much on their mind that they don't learn other things. All four of these programs demonstrate how research gives us the facts to build theory, which gives us the way to reframe what is happening, because that's what theory does. Theory helps you say, oh, it's not this, it's really that. And theory allows us to reframe what is happening so we can practice creatively and be innovative. That's what you've heard this afternoon. So at this point, let me thank the presenters. Let me say to the Greater Minnesota people, I have a script. I'm to say thank you. I'm to say what's happened in Greater Minnesota in the 32 sites is some of them will leave us now. So moderators, if you're going to leave us, we'll say goodbye. And they're using this time to have their own discussions. If you want to stay with us, what's going to happen now for the next 30 or 28 minutes is the presenters are going to come up here, and we're going to take your questions, the atrium questions, and any questions that want to be emailed in. For Greater Minnesota, if you want to email your questions in, you have our email address, which they should know. And hopefully we'll be able to, you can now ask us whatever would be helpful to you. So would you come up and join us? And we'll have microphones, so if there's questions, Ellen's coming around with microphones, so keep us busy. Come on, you've had to sit and listen, so now this is your chance to be active. Okay. So questions. Anyone got a question? Okay. Okay.
I just have a quick question about a scenario, just talking about attachment repair. In the sense you're on a home visit, and just a typical scenario.
Okay.
A child is 18 months old, and you're wondering about attachment in the back of your mind, and they're just really sensitive. They might throw a temper tantrum in that moment. How do you help that parent with attachment repair at that moment?
Okay. So everyone hear that? The child is 18 months old, and you're worried about attachment, and you're with the parent and child, and the child kind of has a collapse and falls apart. How do you help them in that moment?
Well, first of all, you normalize that kids are going to have tantrums, and it's no big deal because kids have that. You can't hear me? First of all, you normalize that kids are going to have tantrums. No big deal. We all have them. Parents have them differently. Kids have them differently. And it's not a crisis about attachment per se. It's a child demonstrating they have big emotions at the moment. So one of the things that we want to do is make the parent less concerned about what they are maybe characterizing as extreme behavior. And second of all, we're going to congratulate the parent that they have a child willing to get distressed so that they can answer the child's needs. Isn't that cool? Because it's a reframe. And then we're going to say, what do you know about children who are distressed? Oh, I'll bet your mom knows something about how to comfort a child.
The only thing I'd add to that that sounds really loud. The only thing I'd add to that real quickly is helping the parent in the moment with some specific things that they can do, but in some ways letting them know and continuing to remind them that these emotional responses, as powerful as they are at the time, they're like arcs and they pass. And if that seems like that's something that's continually or repeatedly difficult to the parent, that after you're through that time, you work on that and a time that's more calm. You know, Anne's graph about the arc and the chart like that, if you can come back when they're in a calm place and have the parent talk about their own experience of that when the child is crying and upset, how does it make them feel, and then do some planning with them so that they can anticipate that feeling that's going to be coming the next time the child has the tantrum, and then practice with you some different ways that they can respond so that it doesn't get so overwhelming for them.
Another question, mine's not loud enough either. Another question that I might ask the parent would be, what is the child trying to tell you with that tantrum? What's the meaning of the tantrum? So clearly, like Deena said, helping the child to regulate, providing some external co-regulation. But then sitting down with the parent and brainstorming about what does that mean? What they're trying to cue you. They have a need. What is it?
I'm also thinking about if you're intervening at the moment, we have to do a lot of de-escalating. We have to sometimes we're joining a parent or with that child in the moment. One idea that's really helped us is the idea of matching intensity. And I think that's an Anne idea. We've all learned from Anne. But matching that intensity with that child, but the child gets to see we're showing them, oh, you're really feeling those big feelings right now. You can say it in your voice, but you're not out of control. You're not losing it. So the child can gravitate to kind of let you be their glue person at that moment. And then we use the good old tools of distraction. We use those good old tools of let's go do something else. I mean, the one story that I'm still amazed by is how we asked our kid a difference between an orange and a peppermint lifesaver once when he was escalating. And he stopped and he said, I think I'll take the orange one. And then he moved on. And it's almost, you can think about, he's flipping out of his blown out of proportion amygdala, and he's moving down into his prefrontal cortex, and he's able to think again. And so sometimes just helping parents understand how that cycle works, how they meet them, and then they can do the talking and the teaching at a calmer time.
So I learned matching intensity from Beatrice Beebe in New York. It also goes around. What that refers to is the normative ability that parents seem to have of matching their child's distress, not consciously. So the baby cries and the parent immediately goes, ah! And then they move that distress either up into a high alert because there's danger, or down. Oh, it's okay, all right. And what Krista is capturing is that verbally and tonally, non-verbally, we help children regulate. What happens to the parent who's panicked about her own ability to manage distress, an attachment task, is that rather than feel like a co-regulator, she feels dysregulated. And so that's what you see is her panic. And all these are ideas of how we join the parent to supplement her confidence and regulation so that she can move her child. Now, all of us have suffered through 18 months. More questions? Questions about individual? Oh, good.
Can you talk a little bit about how to engage like foster parents or adoptive parents? A lot of times I find that the parents will either blame the birth parents or that blame the child. They need to get over it. That was the past. So do you have any tools in engaging foster or adoptive parents?
One of the things that we spend a lot of, we spend a lot of time with parents, and when sometimes we'll do a 2 or 3 hour session, and 2 of those hours are spent with parents. And I think that what we try to do is to listen to their stories, which I'm sure you do as well. But I'm talking hours of stories. listening to their day-to-day life, affirming what they've been through, acknowledging the good work that they've already done, and then asking questions, trying really hard not to open my mouth and give them information and tell them about their child, but just repeatedly asking questions. Well, when they do that, what do you think that's about? Why do they do that? Is that about some past attachment thing, or is it a trauma? Developmentally, where are they when they do that? What do you think they're thinking? What do you think they're feeling when they're in the midst of that horrible, awful behavior? Again, trying to get them underneath the behavior so they can see their child in a different way. But it takes a lot of time.
I think the notion of the core issue of adoption, claiming, as we ask alternative caregivers, foster and adopt families to really claim and love the children, that they're going to have to do a part of claiming and grief work about where the child's history has brought them, and they wouldn't be in that foster adopt family had it not been for the journey that they've taken, and there's a part of joy and a great deal of sadness with that. But recognizing to claim the child's history means to love the whole child. And we cannot put the child in a Solomon position to choose and split their past and their future, that they can claim and love alternative family members and still recognize and grieve and even love the people that they came from. And it's not an either or, and it's hard to feel compassion for people that have hurt children. I get that. And yet most people don't wake up in the morning and say, damn, I'm going to hurt my kids today. That isn't how it happens, not in real families and real lives. So I think attunement plays out in here. Can we be attuned to the original caregivers? Can we feel empathy for the distress they probably had? And then can we acknowledge the child's grief about their history and then process that in a parallel way with them? Might be one idea.
I'll just add a quick plug for MNASAP. Is everybody familiar with Minnesota Adoption Support and Preservation? Did I get that right? It's a wonderful resource for foster families and adoptive parents. They have a great website, newsletter. It goes out all across the state, and they cover a lot of these same topics about how to help foster or adoptive parents either prepare or work with the kids that they're caring for.
A lot of foster parents choose to take children because they feel very expert at parenting, and they've been successful with other children. And one of the biggest difficulties is that these children, just as we have to be humble and learn from them, so do foster and adoptive parents. It has to be dynamic. And these children can make very competent people feel inexpert. Mm-hmm. And that's often what you see is that reactiveness, where suddenly I feel inexpert. I knew how to do it with my other children, and why isn't he letting it work? And that's where the very tragic power struggles come in that we see, and it's painful. So again, if we can remember, these children bring their histories not with intention, and they don't mean to make us feel failed, but they are capable of making us feel failed.
I think sometimes I've talked with parents seem to take heart in thinking about their job as detaching and attaching at the same time. So we can talk about really, almost in a Buddhist sense, what is that detaching? Detaching from that I have to fix this child, I have to change this child. And so sometimes they talk about the lens of when I'm in my mom moment and I get to just be the mom I always wanted to be, you know, chocolate cookies and milk and smothered kisses. But oftentimes I have to be in that coach role where I'm doing this matched and, you know, all these things we've been talking about that they'd rather have treatment center people do, but darn it, they got to do it in their own home. And so there's a grief process around that of parenting the whole child and stretching themselves as a parent to do that as well. And it's just not the role that often they felt they signed up for.
Mm-hmm. This might be time for me to make a comment. This is passed on to me from a person who was here and had to leave early, but it is an adoptive parent who said, I am the adoptive parent of 2 traumatized children. I have found it very, very hard to find competent attachment-related family-centered therapy here in Minnesota, and as a result I've had to rely on tons of books on how to parent these kinds of kids, and trust me, you cannot learn to do this correctly from any book. This is kind of a letter. I found this seminar completely by accident. I challenge this community of committed, caring mental health providers to do a better job of publicizing your existence, or basically the existence of resources for families. We need you, and that's underlined twice, but there are no hearts after it or exclamation points.
Well, I wish you were here so that we could
Yeah, I
agree.
wish so too.
Yeah. Thank you. Thank you. And certainly, you know, these are 4 very viable programs, and I think in our audiences, both here in Greater Minnesota, there are people who are eager to learn how to do this. So we'll reply back. We're on it. Yes.
Yes, I'd like to hear about any strategies you can recommend or success stories of getting parents to re-engage with their children.
Oh, now you'll get them going.
I can tell.
Don't look at me. There's all kinds of stories. You just have to pick them. Go ahead. Go ahead.
This is a quick, I've been thinking about this one the whole time because early on you talked about the thing about dogs. You have to hit the cat hair and then the dogs. And one of the other kids that I worked with was living with his aunt because both the parents, dad was in jail and mom was somewhere else, not there. She wanted absolutely nothing to do with me. There was cultural stuff, it was an African-American family, very, very distrustful of the system, very, very distrustful of me as a white guy coming into their family. And the family worked, but she would not come to Washburn to see me, you know, wanted as little to do with me as possible. I got as far as the front porch, and the one family session I'll never forget is they had a yard with a big fence around it. We would meet on the front porch, and they had about a dozen pit bulls, and then, you know, then the pit bulls kept just breeding with the pit bulls, and there was, every time I came back it seemed like there was more pit bulls. So we were sitting on the porch, and the thing that happened really early on was I thought that this boy needed medication. And you know, medication is a mixed bag. Some kids it makes all the difference, other kids it's just not worth the trouble. She said, that's it, there's no way. And he's not going to get on special ed. I don't want him getting that EBD label. So the family work with her was really talking about how can we work within what you're comfortable about as a parent, and how can we really make it about this, helping this boy be successful. So what we were able to do was keep him off medication, focus on the more internal structure things that we could do through therapy. We got him some special services through the school district under an OHI, other health impaired label, so he wouldn't need the EBD label. But the thing I have to tell you about with the dogs was sitting on the porch, she's sitting across from me, and you know, we're having these conversations. How can we get past some of the mistrust and what I'm trying to do, what your worries are, to make things better for him? I'm sitting there with my back to the windows, and all of a sudden I hear this crash, and then scrape, 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 and I turn around right here, and there's a pit bull right by my shoulder that's just launched itself through the screen window and is trying to get through onto the porch. So she grabbed the dog, pulled it onto
Do you need a job?
the... Yeah.
You're my kind of guy.
So much fun.
No recruiting.
The thing that I'm trying to get at is you have to start by meeting the families with where they're at, and you have to come to it with an idea of what do I have to offer you, you know? And how can we find something that's going to be beneficial to you, it's going to be beneficial to the kid, and it's going to help me get my job.
Often the families that are referred to our center are at the end of their rope. I mean, they've been in all kinds of therapies, they have talked to all kinds of professionals who have given them advice or not believe their stories. And so when they get to us, they're pretty burnt out. And so when they enter into the process of doing claiming and belonging work and a narrative, it's like, I don't feel this. Can I fake it? Is that okay? And yes, that is okay. And just 2 weeks ago, I worked with a family where they were going in kind of faking it, going through the motions of it. On the third day and every day the mom would come in with a list of things she wanted to be sure to tell me about the child and the behaviors the child had had overnight or since the last session. The third day she came in and said, I'm beginning to realize that if I had done this stuff, this claiming stuff with this kid, if I had had this child since the beginning, she wouldn't be like this, would she? And so it's part of the process as well of spending the time and listening and engaging them in that way.
So Denise, tell us, what did you say to her when she said that?
I just smiled.
Yeah. Yeah.
It's hard to top. It's hard for me to. You can't top that.
Yeah. Well, I'm thinking of that example and Tom's example of the girl taking his hands. You know, we use a lot of theory. I mean, you heard I have words and words and words. You don't need to use that with families. Families don't need to be educated to the intricacies of attachment. They just need to be helped to, in the moment, experience something different. You know, so that's a lovely example.
Could I just add one other thought too to that? Just like getting up here, as many times as I've talked to groups, I still am terrified and anxious every time right before I get up and have to do it. And especially with newer therapists, the thing that I'm so struck by, we keep talking about that for kids, a lot of the core of this is anxiety and fear. And especially for younger, newer therapists, I know the first couple years I was doing this, I was terrified all the time. I was anxious, I was worried, did I know what I was doing? Am I harming this kid? And one thing that I see being so hard for a lot of newer therapists is getting comfortable with your own anxiety and being able to process that and in some ways narrate it in a way. You know, a lot of times you go in thinking, I have to know what to do, I have to have all the answers for this family. And the more you can get comfortable in those moments where you really don't know what to do, or if you're worried or confused, to be comfortable with that, to sit with it, and to really express it with the families. A lot of times a way of engaging them that I think works really well with newer therapists is when you get at that moment is saying, you know, I'm kind of confused right now, or I'm worried about what just happened and I'm not quite sure what to do. Can we try to figure this out together? You know, the more that the family feels like you're in it with them and you're trying to figure this out together, I think that's another way of engaging them.
I also think that when parents are reluctant to re-engage with kids, it's for a very good reason. And I think as a system, we want to own that we weren't there for you, and you don't want to engage because it's so damn painful, and you wouldn't be at the place you are had you had more support, knowledge, training, wisdom, whatever. So I get why they might be gun-shy of getting back into the fray, and somehow to step to the plate and say, we're not going to leave you this time. We won't abandon you as you try to do this process. We should have been there the first time. Maybe we can help you this time and get it right.
On a real basic level, we try to use the language of play and sensory baskets, for instance, of having a basket of various sound makers. And you'll be sitting around in a family circle with siblings and parents, and they're all there in residential treatment, and we'll start passing around this sound maker and shaking it and making sounds like storms. And what usually in that kind of encounter, we're not talking about much, but stories start to emerge. Remember that time when there was that big thunderstorm and we all had to hid under the couch? And that's where we try to start seeing where those moments of connection can get warmed up again in terms of the parent and the child being together. And if there's a little bit of touch, or there's a little bit of eye contact, or then you might see that child nestling in a little bit more as we're talking about watching that scary movie. And then asking them to practice things like that at home, because home passes are so critically part of our program, is make it real at home. So they're intentionally seeking out shared experiences that involve the five senses as a beginning of rebuilding.
Dan, you made a comment earlier about how the child will teach you what needs to be done. And I wondered if you could elaborate on that comment, first of all, and then maybe if the programs could too talk about how, from their perspective, that's incorporated.
The child will teach you if you have the research and theory. Right? If you don't have the understanding of what attachment is and what attachment disruption does, and you don't understand what we've learned, then the child will teach you to feel chaotic. And you'll do what is intuitive, which is push the child away. And that's what we see happening again and again in community practice, where these children alienate themselves from not just their primary experiences, but secondary and tertiary experiences. We push them away. We put them in timeout, we exclude them, we suspend them. So if you have, that's an important qualifier, if you have the understanding of the research and theory, then what it allows you to do is become part of that mutually regulating system, that new mutually regulating system. And when the child does make you feel dysregulated, as Krista says, you learn not to take it personally. You learn not to react as if this is something that the child is doing on purpose, the aggressive side, or, oh my gosh, I never learned anything in school, the imploding side. You learn not to take it personally. You learn to say, this is interesting. You learn to be reflective. You know, one of the primary areas of early intervention attachment research is on reflective functioning. And how do we teach young parents to think about their baby's experience? And in the same way, how do we learn how to think about the child's experience? So you walk out and you say, that didn't go well. I wonder what was going on. That was interesting. And then you find yourself the next morning taking a shower or driving to work or dropping off your dry cleaning. And you say, oh, that's what happened. Right? Now, without the theory, you can't get those insights. But with the theory, you can tolerate your own distress enough to have the child help you know what they need. And then it's not that you're passive and following their lead. It's that both parts of the system are active and both parts help each other out. Just as in my drawing, the adult has more resources. So I can go back and say to that child, you know, yesterday when that happened and it turned into a mess, I think I figured it out. Or one of the favorite phrases with children, you know, I was thinking about you. You just see their whole experience open up. I was thinking about you last night, and this is what I figured out. Now, that's what I mean by the child will teach you. So let's ask, what examples do you have? Or do you think that's right?
Yeah, well, I think it's right. Todd, that's a great question. And I agree with Ann that when we do assessments, I know your center does them, we do them, you can't get a good clinical assessment if the person doing the observations really does not understand the subtleties of, I think, attachment formations in theory. And that's at one level. On the other level, every day, this summer, a 17-year-old girl, and I've studied PTSD and understand medication is good. She had to take trazodone because she was so anxious, couldn't fall asleep, sleep-deprived kid. And she was in residential care. I went to see her, and she was essentially in lockdown because she refused to take her trazodone at night to sleep. And so she had a lot of consequences happening for her, and it was a big power struggle with the staff. I asked her, why is it you're not wanting to take your trazodone? And she said, well, I've been having such terrible nightmares, which happen to be actually memories for her, that when I take my trazodone, I have to stay in my nightmare a lot longer because I can't make myself wake up. And listening to this child's story educated me because I sort of got immediately what she was talking about. And to the center's credit, they were able to listen to her correctly and make some pretty significant changes in their practice and thinking about what we thought was standard operating procedure for kids that needed help in falling asleep. So I think the theory practice piece has to go together and then go back to attunement. If we're really attuned listeners, we're going to let those children lead us in a way if we have the courage.
Helen's telling us it's time to go.
No, actually, I'm going to say I have one more question.
Oh, okay.
Because it came in from Rochester, and
Okay,
I don't want to let this
Rochester,
one
we're
go. So this
listening.
is our last question for today. And it's from a caseworker who says that she's worked with a girl who had neglect and abuse issues since she was 2 months old and has very severe attachment issues and has ended up pigeonholed in correctional services now as a teenager. What can I as a case manager do that will help?
Oh, caseworker in Rochester. We need more than 2 minutes. 2 minutes.
Yeah.
Let's organize it quickly and then we'll add on. You know, this girl has probably never had reliable care. And so she's a tragic example of when we neglect early intervention and allow neglect and abuse to continue, how the person who pays is the child. And she's in the correction system because that's what happens. These children get aggressive, they get disconnected, they don't feel part of the club, and they feel like the world is not going to take care of them. So we see that. Now, our hope is that the correction system is also represented here. Is anyone from corrections? Oh, we have work to do. Oh, hooray! We need the correction system here. You know, we hear statistics that, 60%, 70% of juveniles in the correction system have undiagnosed mental health disorders. Often they are these kind of disorders. And so if we're really going to be preventative as a culture, we need to grapple with how we do child protection. We need to grapple how we deal with neglect. We need to stay aware when these children get to corrections to see them as vulnerable and not only intentional. And we need to keep thinking of repair. So I wish we had better answers, and you're welcome to email any of us and we'll help you out. All right. I heard, this is unpublished or yet to be published, but a colleague in Boston was looking at adolescent sexual predators, and he found greater than having been abused, being in an out-of-home placement 5 or more times predicted sexual predator. And it's a very compelling research finding because it captures that need to be connected. And if you can't be connected in a positive pro-social way, you'll connect in a very bad way or very bad ways. So thank you all, especially thank you to our panelists. Thank you to the audience. And remember to tell us what you want next.
I have just a couple comments before you leave. First of all, this series has all been about connecting research and practice, and I don't know that I've ever been with a group of people who can more eloquently move between the real technical concepts related to research and theory and brain development and medication and diagnoses than this group here. So please just join me again in thanking each one of them. Their wisdom in taking that information and making it seem like common sense, which we know it isn't, in working with families is really impressive. I want to also ask you to join me in thanking Ellen Lipinski, who is our events planner for this series and has done a fabulous job this year. Also, a reminder, someone did leave their keys, I think, in the restroom, and we have those up here. Please also complete your evaluation forms. We really would love to have your input for planning our series next year, and you can pick up certificates of attendance on the way out. Thank you very much.